Hello, 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 my wonderful icy friends. I hope that you are doing well today. This is the last Sunday before Christmas for those of us who celebrate Christmas. And I know that there are lots and lots of other things that you would be like to be doing, but I also know that some of you might be having flares right now, and that's why I'm here. And I will say I'm a little marginal today because I had my booster shot and it kicked me in the ass. I'm telling you, the booster shot had me basically on my recliner for a couple of days. All right, now hold on a sec. I'm having an issue here. Ah, there it is. Hold on. We are simulcasting live on Facebook and YouTube. And let's see here. Get over here, you little son of a gun. There we go. There we go. All right. And of course, how are we doing? Do we look good? How does it look? All right, that might be a good compromise. I'm working in front of, nope, I'm working in front of two computers right now. I got YouTube over the computer on my left. I got Facebook on my YouTube. I've got Facebook on the computer I'm sitting directly in front of. They have had different, they have different challenges here too. Lisa says, me too, for a whole week. The underarm and breast lymph node swelling. Oh my God. Lisa, are Oh, you are so right. I woke up yesterday. I had my booster Thursday afternoon, right? And like that night at like 4 in the morning, I started shaking like a leaf. And let me tell you, when you have TMJ and your jaw is doing this, I was so cold. Like, oh my God, I was so freaking cold. Went and got a heating pad, put it on my chest, got myself to stop shivering after about 30 minutes. And then the headache hit. The headache of headaches of headaches. That I still have a little bit today. Hey guys, hold on one sec. This person keeps calling. Hold on. IC Network, this is Jill. Yes, hon, we're doing a live support group meeting right now. It's Sunday. I don't have any staff here. If you want to give me your phone number, I can call you back, but it's not going to be for several hours because we're doing a live support group meeting. That would be great. Thank you, hon. Thank you so much. Bye-bye. Okay. Yes. We do not work on Sundays except me. I work on Sundays. All right. So anyway, the Pfizer booster drama. All right. So then the headache hit for a couple of days. And then yesterday I woke up with these giant swollen lymph nodes under my left armpit and in my breast. It's like, oh my God. Like, wow. So Lisa, I hear your pain. And Sylviane said she had the booster. It hit her hard. Sue says starting vaginal suppositories on Wednesdays. Fingers crossed. Awesome. Good luck, hon. What kind of suppositories you're getting? I'm assuming it's going to be a vaginal Valium suppository, which is the right thing to do. Although it could be estrogen. Hi, Sylviane. Hi, Laura. Hello, Suzanne. Yeah, I wasn't sure if I was going to do this today, to be quite honest, because I'm like 60%, but then I was just like going, listen, I'm sure there's somebody out there who's having a flare. Let's see what we can do to give a little bit of tips and help to kind of get you through the holidays. And I also wanted to share with you a very interesting conference I went to. But even more so, I'm going to be just a wee bit controversial here. I know that some of you trust me, and the reason why you come is because you really do trust me, and I work hard for that, and I hope that I've earned that trust. And I want to talk just a little bit about COVID and the holidays right now. We have one job. and that is to protect our families, right? That is our job, to protect our families. And the Omicron virus is terrifying doctors in the United States right now. It is doubling every 1.5 days. It is a terrible risk right now that even though it has milder symptoms, we have no data on what it can do to long haul COVID. And there are millions with long haul COVID now. And so I had this little thing. Hi, Mary. Here it is, my friends. Here it is. Whoops. Let's stay home, shall we? Let's stay home. You know, never in our lives could we have imagined what we're going through right now. Hi, Kareem from Belgium. It is like being in a surreal science fiction movie. It is, you know, the stress that we are all under is real, but the physical threat that we are under is tangible. It is devastating, and it is scary as hell. And so we can do another Christmas at home. And I really, really, really encourage you to stay home. If you have people that are coming to visit, ask them to do a over-the-counter COVID test first. And honestly, go buy a handful, have them at your door. We just have to be smart here. And we've got to protect those people around us. I'm not having anybody come to our house, even my sister and my brother-in-law, because they are going to have a lot of exposures this week with other family members coming from other parts of the country. And I've got a 99-year-old and a 92-year-old who's just recovering from pneumonia. And so we are going to do Christmas alone this year, and that is fine. We have Zoom. So please, please, please be careful, okay? If you can, stay at home, please. Okay. So normally, well, first of all, let me introduce myself. Yeah, Donna says it's just marking you. Exactly, Donna. Exactly the right thing to do. So let me introduce myself for a moment. Jill Osborne, President and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States. It will be 29 years and counting soon. I bring to you a whole bunch of degrees, which you don't even need to know about, including sitting on the U.S. Army IC research panel for about a decade, allocating millions of dollars of research for IC. And so I kind of bring multiple balances here when I come to these meetings. I wear multiple hats. Number one, I'm a support group leader. I have a master's in psychology, and my IC network was my PhD doctoral dissertation in how to bring support to people who were homebound, which ironically I couldn't finish because I couldn't sit in the car and drive to school because the pain was so bad for 5 years. But it is very exciting to me that 29 years later, the IC network, my little doctoral dissertation proposal, continues to be rated number one in the world by Harvard Medical School and the University of London. So we've got some good things happening here on the IC network website. I'm also an IC patient. I had my first symptoms when I was in 7th grade. I'm a chronic overlapping pain condition patient. I had the frequency urgency in 7th grade. Then I had vulvodynia in high school. Then I had IBS in my 20s, et cetera, et cetera. What we know is IC subtype 5. And I am here to tell you that this is not an incurable disease of the bladder anymore. We don't think that anymore. We haven't thought that for 10 years now. We think of IC as a pelvic pain syndrome. Why? Because other structures are often involved, if not dominantly involved. If not dominantly involved. So for many of us, there are muscle injuries. For others, there are central nervous system issues. Some people, yes, some people legitimately have something going on with their bladder wall, whether it's estrogen atrophy or chemical irritation or whatever. It's absolutely possible that the bladder can be part of the problem. But if bladder therapies aren't working for you, if you're getting worse rather than better, if your bladder is normal when they look at it instead of abnormal, then it's time to look beyond the bladder, right? So anyway, I walk in your shoes. I know what it's like to be up all night crying and not having help. I know what it's like to pray to God for a little bit of guidance there. And I am living proof that you can get better, because guess what? I haven't had severe pain in about 10 years now. I once had a doctor say to me, "You will forever be a burden on your family. You will always live with severe pain. Get used to it. This is your life." He was effing wrong. That was the moment I started fighting. When he said that to me in the emergency room, I went, wait a second. I will prove you wrong, you son of a bitch. How dare you say that to me? I still have my degrees. I still have my brain. I still have my heart. I still have my soul. I still have my hands. I'm going to fight. And that's what I did. I fought. I left that emergency room and dove into the research. I got involved. I went to support group meetings. I learned everything I could about this because I refused to let somebody tell me I would be a burden on my family. And he was wrong, because I'm better. And I'm here to do these meetings to help you find that answer too. No shame, no blame. This is not your fault. And you know, like the best part of my job, I got to tell you, the best part of my job is to find that 21, 22, 23-year-old, the me back in my 20s, going through all that agony of doubt, self-doubt, and feeling punished and feeling like it was my fault, and you know, all of that. And to tell them what nobody told me, that this is not your fault. You haven't done anything wrong. There is no shame. There is no blame. Sherry, thank you so much for the 50 stars. So anyway, I'm an educator. I also do research. We do a lot of research on the IC network, including some of the research that led to the Elmeron pigmentary maculopathy FDA warning, as well as some of the only research that's been done with IC and COVID. So there you go. When I do these meetings, we normally have a little 30-minute little mini lecture, introduction, something like that. And then I'm happy to take your questions. Let us hope that the Tylenol continues to kick in with my booster headache. If I continue to feel good, I will stay. But if my headache takes a turn for the worse, and those of you who have had the booster, you know all about this headache, then we might need to shut things down. Okay. Hi, Barbara. Hi, Mary. Mary daughter is Zooming a cookie party. Very nice. That's wonderful. Okay. So here's what I did about a week ago. I got to participate in the International IC Patient Support Meeting, a big Zoom meeting that included leaders from all of the IC support groups, IC patient organizations from around the world. Now, we had a dream about doing this 20 to 25 years ago, actually 25 years ago. We used to call it the IC Patient Network, the International IC Patient Network, but there were a lot of politics back then. Groups were fighting with each other back then, and it just didn't work. So today we have a new international group that's run by a group leader from India and a group leader, I think, from the Netherlands. So I just kind of wanted to go over some of the things we learned about, because, you know, ultimately, like, I've worked with IC patients in 92 countries. 92 countries. Can you believe it? It's everywhere. Pelvic injury is everywhere. Remember, a lot of you can develop symptoms after falling and breaking your tailbone. Yes, you might have symptoms of frequency, urgency, pressure, pain, but guess what? It's actually, for some of you, the result of a musculoskeletal issue. So IC certainly can be in every country, 92 countries here on the IC network. And there are moments when we like to think that, gee, gosh, our country is so backwards, and yet it's not. And for those of us that are in the United States, you know, guys, listen, we got it good in the United States. Other countries are really, really, really struggling to get recognition, get support, getting researchers on their side, getting doctors to support their work. So in India, we have a new group in India that's been around for a couple of years now. They had particularly deep concerns about the theory of IC as being embedded infection. They just aren't ready to jump on that bandwagon at all. And we all had serious concerns about the overuse of antibiotics for the treatment of IC. That was one of the things that they kind of talked about. In Israel, they are trying to get bladder installations reimbursed by health insurance. Can you imagine not having your basic bladder instills covered by your health insurance? Well, they're not in Israel. They're working on a vaginal thermal non-ablative treatment for IC. I do not understand that at all. They also have a new clinical trial of a gel that contains lidocaine and oxybutynin. It's a liquid that enters the bladder and becomes a solid and attaches to the epithelium. It's supposed to be helpful for spasms and chronic pain. And it apparently lasts for 2 weeks. We don't have anything like that in the United States yet. The United Kingdom says that a few more doctors now are following Dr. James Malone Lee's work for treating embedded infection. In Hungary, their goal is to try to maintain a stable neutral pH in urine. Also, unfortunately, Elmaron is now available in Hungary, and they are not educating. I mean, I'm not saying the patient organization. I'm just saying in general, letting patients and doctors know that Elmaron is linked to this retinal eye disease is a little iffy. We want to let all those patients know that they run the risk of developing a retinal disease using Elmaron. So it looks like there is more education is going to be needed on the part of the pharmaceutical company to make sure that patients know the risk of Elmaron. Also in Europe, a doctor, and I don't remember the name of the doctor, he developed, I think it's called the Eurojet. It's a new way to do a bladder installation, not using a catheter. It's a small little device that ends up being filled with the medicine. You stick it at your urethra. I think you squeeze it, and bam, it just goes right up into the bladder. And I do believe that that is what they do in Hungary now. So in Hungary, it sounded like, now I might have this wrong. I'm going to try to see if I can get articles from all of these other different patient representatives so that we can learn a little bit more about that. But in Hungary, at least, it sounded like many patients have access to doing self-installations with this new medical device whenever they flare. So that's pretty cool, right? Spain. The IC support group in Spain has 0 scientific support from the Spain Medical Association right now. That's something they're really trying to gain. They are also doing virtual IC support group meetings. I applaud them. The more, the better. They are surveying, doing something right now on platelet-rich plasma. And something with public toilets, but I didn't quite understand that. Denmark has had an IC support group, I think, for at least 10 years. They have meetings in Copenhagen. They have about 10 or so people that participate. They also have a meeting in Jutland, but it's really hard to get people to show, which is classic, guys. You got to understand. I mean, listen, take it from somebody who's been there. It's really easy to take support groups for granted. When I started my first support group, IC Redwood Empire in Northern California, we did meetings every month. And about 6 months into it, people started 6-8 months into it, people stopped coming. And I do all this work and prep to prepare for this. I'd have photocopies of all these articles. And, man, I had 300 people in my group. I was really trying to do everything I could for them. But then I noticed that people stopped coming as much. And I would ask them why. And they go, well, you'll be there next month. You'll be there next month. And they were really taking for granted the work that I was doing. So then I switched to every 2 months. Did that for a couple of years. And then we switched to quarterly. And then, of course, all the internet and the IC network and everything took off. And it was just, every group has its time. Every group has a space. And the one thing we certainly know is every group leader is going to burn out. I'm kind of the exception to the rule because I really love doing what I'm doing and it's my career. But if support group leaders don't have help, they're not going to last very long. And I've always had a lot of help. And I've always had a lot of people are very, very nice to me. So, for Denmark, they're going through exactly what we all go through, what we have all been through. It is hard to get people to come to meetings after a while. Keep on keeping on, my friends. Keep on keeping on. In France, they now have a new quarterly newsletter for their patients. And Elmeron costs 500 euros a month. Now, what is the conversion of euros to dollars? Just out of curiosity. Let's see. Okay, so 500 euros is $562 a month. Yeah. Disappointing. And the Netherlands also is trying to get bladder installations approved. So that's just kind of a little intro into kind of, what's happening in some of the other countries with IC. We did have a support group. There was a support group or an attempt to do a support group in South Africa. I'm not sure what happened with that. There was a group in Mexico, but that leader apparently moved to Germany. So the Mexico group dropped. I thought there was a support group in Brazil or Argentina. And you know who, where we really, really need a national support group is Australia. The Australian group, Australia IC patients, New Zealand IC patients really go through hell trying to get care. I know because I call you back in Australia on my dime when you call me crying. It's very, very difficult to get IC support in Australia specifically. Canada has a new IC national patient organization. Hopefully they will take off a little bit. Haven't talked with them recently. There you go. So things are definitely happening. All right, let's take a look at your questions here. And man, see, now the other thing I got with the booster is I go from hot to cold to hot to cold. Anybody else do that? I was cold like 15 minutes ago, and now I'm all hot and sweaty. That's crazy. Okay. David said, "Did Monica contact me?" No, not that I'm aware of. But hun, I was down. Listen, I was down. We had nobody working at the IC Network Friday. Nothing. Well, I don't know how many phone messages we have. Every single person that works for me was sick, including me. And so if I have a phone message or email from her, I have no clue, hun. I'm going to be catching up tomorrow. Hi, Susan. Denise, how did you get the pain to stop? So, Denise, the big part was really figuring out where the pain was coming from. This is something that I constantly reinforce in my meetings. The concept of cause versus effect. The pain is the effect. We have to understand and figure out the underlying cause of that pain, right? And because the pelvis is a very small confined area, nothing operates in isolation in the pelvis. Let me get my little model and let's do this here real quick. Okay, so, and excuse my casualness. This is what it is today. Okay, so Dr. Jerome Weiss in his book, Breaking Through Chronic Pelvic Pain, which in my opinion is the best single book ever written for pelvic pain, which I tell everybody to get. It is so good. And it's free on Kindle Unlimited, so seriously, no excuses. He said in his book that Western medicine fails the IC patient and the pelvic pain patient because doctors like to play in their sandbox. Urologists like to stay in the urinary tract. Gynecologists like to stay in the reproductive tract. Gastroenterologists like to stay in the bowel. But the problem is none of these operate in isolation. They influence each other massively. And you can see this in this model. So you can see just how connected everything is. So let's just go ahead and let me just put on my various structures on this model. All right. So the first thing I've done is I put on the levator ani muscles down at the bottom, which are our lowest muscles. And then we're going to put in for a female, we're going to put in the vagina and the uterus and the ovaries. Then we're going to put in the bowel. Okay, my bladder has done a runner. Where's my bladder? Where did it go? Oh, here it is. All right. What is that? And then, of course, we have our bladder, right? So, I mean, this isn't perfect, obviously, but I just really want you to have have an understanding of just how complex and full the pelvic cavity is. And of course, throughout that cavity, we have muscles skeletal muscles that provide, that connect your torso with your hips and your legs with your pelvis, and muscles that help you open your legs to the left and to the right, like this, right? So we've got important skeletal muscles that are happening in the pelvis. And then, of course, we got blood vessels that are flowing through the pelvis down into your legs. And we have nerves that are flowing through the pelvis down into your legs. And I really want you to take a look at this little baby right here. This is the tailbone, right? So we have your skeleton. We have your spine right here. Then we have your sacrum. And your sacrum is a triangular bone that connects your spinal cord with your hips, correct? And the last little bone that comes off of this is, in fact, right here, your tailbone. Now, I want you to look at all the things that attach right here. We have ligaments that attach right here. We have muscles that attach right here. If you fall and you break your tailbone and it heals out of position, it can cause all the symptoms you associate with IC. We're really looking at musculoskeletal issues right now and the role that it plays. So again, Dr. Jerome Weiss says Western medicine fails the pelvic pain patient. Why? Because structures outside of the pelvis are often involved, if not driving, these symptoms. We have two reflexes in the pelvis that you need to understand. The first one is called the viscerosomatic reflex. Viscero standing for organ, soma standing for muscle. So the question is can an organ change muscle behavior? The answer is, oh, hell, absolutely. Because if you're in pain, let's say you're having your period, let's say you're having IBS and you're having diarrhea, or you're having severe bladder pain, your muscles will get tight to protect you from the pain. That is called the viscerosomatic reflex. So that's proof that an organ can change muscle behavior. But can a muscle change organ behavior? That's a far more important reflex to pay attention to. If you hurt a muscle, can that change the way the bladder functions? Can that change your bladder symptoms? And the answer is yeah, it can. It absolutely can. Because a muscle that's tight causes ischemia. Ischemia is oxygen deprivation. It's poor blood circulation. It means the tissues and the organs in that area are not getting good blood supply and good oxygenation. So is the bladder going to be healthy if it's only getting 10 units of blood when it's supposed to get 28 units of blood or 24 units of blood? The answer is no. The bladder is probably not going to be that healthy. But then the other thing that happens is when you have tight muscles, in addition to reduced blood supply to the organs, you have reduced blood supply to the nerves. And then the nerves start functioning much more poorly. And then we have neuroinflammation. And then that also is going to affect the bladder wall. So nothing operates in isolation. So you as the patient, you are the detective here. It is your job you never, ever, 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 ever walk into a doctor's office and say you have IC. Never. If you're going for a second opinion, do not walk down that mousetrap. Your job is to walk in and describe your symptoms in detail, in depth. And the devil is in the details because it's that little tiny rare symptom that you only get once a week that's probably going to figure it out for you. So if, for example, you have pain that shoots down your leg every now and then called sciatica. Okay, you have pelvic floor dysfunction. That means your muscles are screwed up. Your muscles are too tight. Do you have a painful arousal sensation every now and then where you feel aroused but it hurts? Okay, again, that's proof that you have pelvic floor dysfunction, muscles so tight they're compromising nerves. Do you have pain not before urination, but after urination? So if it were just your bladder wall, let's just say you're thinking all this time that you've got this messed up bladder wall. Let me get a picture for a moment. I want to explain this. Okay. It is an undeniable fact. Ooh, now I'm hot again. Sorry. Okay. Okay. So back in the days when we all thought IC was a real incurable bladder disease, why did so many of us, about 85%, 90% of us, have normal bladders? Isn't that interesting? Because again, for us, it wasn't a bladder issue. But let's take a look at what they often do see when they look in the bladders of some IC patients. These are Hunner's lesions. 5 to 10%, maybe 15% of IC patients appear to have Hunner's lesions. This is a perfect one for you to look at right here because it's known for having what we call a stellate appearance. It's kind of like a star, right? So there's a center red spot. A center red spot with arms that radiate out, areas of inflammation that radiate out. This is the equivalent of an open wound in the bladder. And I mean, you can see, like, look at this one right here. I mean, that's a perfect example also of a Hunner's lesion. Now, I can absolutely promise you that if you have Hunner's lesions, urine is going into this wound and it's going to hurt like hell. It's a wound. It's an open wound in the bladder. And so as the bladder fills with urine and you get more and more and more urine on that wound, it's going to get worse and worse and worse and worse. And then as soon as you empty your bladder, you feel better. Why? Because urine is no longer on the wound. Give me one sec. My mom is calling me. She's 92 years old. Give me a moment. Yeah. I'm doing a support group meeting.
Oh, I thought you weren't going to have it.
No, I am doing it. Okay. It's our last meeting before Christmas. It's very cold outside.
Oh, look how wet the window is. Has it been raining?
No, that's just steam. And I've already made your tea. How do you feel? Yeah, me too. Okay, you got your underwear on. Excellent. And your shoes. Where are your shoes?
Oh,
Okay.
thank you.
Okay, I'm gonna let Dad do your breakfast. There's your, the English muffins are right on the counter, but they're not toasted.
Oh,
Okay?
thank you.
You're welcome. Love you, Mom. Oh, okay. Sorry about that. She needed help snapping her robe and me putting her hair in a ponytail. She used to have short hair. It's now down to the middle of her back, and it's gorgeous, gorgeous. She looks so much younger with this beautiful long hair. That's kind of where I got my hair from. It's amazing. Okay, so where was I? All right, so the devil is in the details here with respect to your ability to describe your symptoms and get your doctor to study your pelvis objectively. So again, if you got pain shooting down your leg, also known as sciatica, you got tight muscles. If you've got persistent genital arousal disorder, you've got tight muscles. But if you have pain as your bladder fills with urine that is relieved by urination, and if you're down to eating like 3 or 4 foods because every single thing hurts, you could have Hunner's lesions. Hunner's lesions are agonizing, giant open wounds in the bladder. And when urine touches these wounds, it hurts like hell. And I think one of the greatest tragedies in my work are those patients who call me and they've been in pain for years. I mean, years. They're bedbound, they're homebound. And they have Hunner's lesions that were never freaking treated. Never treated. It's malpractice. When you treat Hunner's lesions, what do you think happens? For 85% of patients, the pain goes away. And so if you have Hunner's lesions, you need to understand that things like Elmeron and bladder installations are not going to be effective. What's going to be effective is them lasering these lesions or cauterizing these lesions, which a laser does, or injecting a steroid in the lesions, or maybe hyperbaric oxygen therapy. Right? So this again, 5 to 10% of patients. We also have a clue as to what's causing these lesions. Because in some of you, it appears to be a virus. Can we say COVID? We now know COVID can infect the bladder in the most severe COVID patients, not in mild patients. But COVID cystitis is, well, we also call it de novo cystitis, are patients with no previous history of interstitial cystitis or any bladder issues at all, who suddenly after COVID, they've got all the symptoms you associate with IC or overactive bladder: frequency, urgency, pain, discomfort. It's huge. Our groups are going to be filled with COVID cystitis patients for the next 20 years. I have no doubt. I have no doubt. And that is from the cytokine storm, the massive inflammatory reaction happening in COVID, or potentially an active virus in COVID. I know that there was a research study that talked about men who had erectile dysfunction after COVID. And as they were trying to figure out what was going on with these men, now we certainly do know that COVID yes, it is spread through the air, but it doesn't just attack the lungs. It attacks the various parts of the body through the circulatory system. It attacks the circulatory system. It appears to even attack nerves too. There's just still a lot that we don't know. But we do know that patients with COVID get blood clots. We do know patients with COVID have lost limbs because of the blood clots from COVID. And so it's not a big stretch to understand why some men with COVID end up with erectile dysfunction. Elke said, Elke, what did you say here? Aki says, do you still take brief calls for a fee? Obviously, honey, I take brief calls all the time for free. They're not a fee. It's free. You can call the IC network anytime you want, as long as it's not a weekend. Sometimes you'll get me answering the phone, and sometimes you'll be on a big list of me for people to call back. She says, I'm depressed since my 2 Pfizer jabs in May. Any without cholinergic effects, 4 installations in January, you're afraid to go. Honey, I'd be happy to talk to you this week. You took Flexeril for 2 weeks, 3 times a day, hurt my back, and you went into remission, but it came back. No hunters. Yeah, but honey, alcohol. So the Flexeril relaxes your muscles, but so does alcohol. Well, we got a lot to think about there. All right. So again, these are going to be the most severe patient. These are the patients who are going to have the hardest time getting care. And this is why, if your pain is persisting over time and it's getting worse rather than better, eventually you want to let somebody look. Because if they look and find this, they can treat this. But, if you let fear stop you from letting somebody do a proper diagnostic examination for you, you could end up in a world of pain for years. And we don't want that to happen. I mean, my approach for my body is, if I'm in pain, I want somebody to look at and figure out why I'm in pain. Just look at it. That's why an in-office cystoscopy is reasonable. I call it a looky-loo. They just numb your urethra, stick a cystoscope in, take a look around, pull it out, you're done. And that will give them a chance to take a very quick look at your bladder. Do you have a bladder stone floating around in your bladder? You want to see a bladder stone? That's the Himalayas of bladder stones right now. If you got bladder stones, that could be causing all these symptoms you associate with IC. Do you see how rough it is? Do you see all those rough, sharp edges? If this little sucker is floating around in your bladder, it's too big to come out of your urethra, and it's scratching everything it's touching, yeah, that's going to hurt. A cystoscopy will allow them to see that, potentially break it up and get it out. So that's something reasonable for them to look for. Okay. But here's the thing that we used to think was IC. These are called petechial hemorrhages, or also known as glomurulations. And in 1987, when the U.S. National Health Institutes of Health created its first diagnostic criteria for IC, they required that a patient have this or this, right? How do I want to say this? I mean, I love science, but science is so disappointing at times. They invented the cystoscope in the early 1900s, and then, doctors got together, researchers got together. They're trying to create new and interesting and innovative ways to look at the bladder. So they started putting more fluid in the bladder to maybe stretch the bladder out, help them visualize the bladder wall, et cetera, et cetera, et cetera. And what they started seeing with the new cystoscopes, along with these new methods, are these petechial hemorrhaging. And so that's when they do a hydrodistension. They fill the bladder with fluid, keep the fluid in the bladder for a period of time, drain it out, fill it up again, drain it out, and then they take a look at the bladder. Well, what have we learned? About a year after the National Institutes of Health said, hey, this is IC, another researcher said, well, no, that's really not IC. That's actually from the test. And he took 50 women with no history of bladder issues who were going to have a tubal ligation. And he said, would you please let me look in your bladder and see and just test something here? And he got these women to do that. And what do you think happened? In all these normal women, they had these two. Why? because when you stretch the bladder, things break, blood vessels break. And so the finding of petechial hemorrhaging and glomerations in the bladder are now, it's considered unimportant. It's considered basically a residual of the test itself. Okay, so there you go. There you go. Now here's something else that's kind of interesting. Do you feel a heaviness? You feel like you're carrying a bowling ball around in your pelvis? And as the day goes on and on and on and on, it gets heavier and heavier and heavier until bam, by the end of the day, you feel like you can barely take a step. You got some heaviness going on there. And you're peeing all the time. Well, guess what, my friends? That is called pelvic congestion syndrome. It's the equivalent of varicose veins in your pelvis. It means that you've got dilated veins in your pelvis that are collecting blood. And it's getting heavier and heavier and heavier. And gravity makes a difference when sitting up, standing down, movement, bearing weight tends to be more uncomfortable as you've got all of this blood flow flowing in there. Another thing is, I would want to know, do you have fibroid tumors? Because here's what we know about 70 to 80% of IC patients with fibroid tumors. Guess what? They've got the symptoms of IC. Why? Because the fibroid tumors are pushing on the bladder. So you, my friend, are an anatomical mystery to be solved. Your job is to get somebody to study your pelvis. Be the squeaky wheel, not the angry wheel, not the rude wheel, but the squeaky wheel. Mary says here on YouTube, yes to the heaviness sensation. Absolutely. Elke says, we'll call this week. Best time, happy to donate. I usually am not going to be able to spend time with people until afternoon Pacific time. Let me look at my schedule here real quick for this week. Yeah, I think if you call like after 1 o'clock Pacific time, that's great. That would be good for me. Just know it's first come, first serve, and I'm going to go through all my messages earlier and put y'all in a row and just call back whenever I can. And please know that I tend to call back late. So if it's 5 o'clock in California and it's 8 o'clock in New York, guess what? You're going to get a phone call at 8 o'clock. So be prepared for late phone calls. If you can't do a late phone call, you got to leave that in your message because I work late. Because I do elder care in the morning, obviously. Elke says, yes, exactly what I told the doctor. Bowling ball, no hunters, just little glomerations, no fibroid tumors. So this is when you would go to what we call an interventional radiologist. An interventional radiologist. They're the ones who can use a sonogram to identify if you have pelvic congestion syndrome. And Elke, if you email me, my email address is icnetwork@mac.com. I will find the magazine that we did a big article on this, and I will email that to you if I can find it, or you can just become a member and you can look at all the magazines on your member page. All right. But the bowling ball, yeah, really going to look at pelvic congestion syndrome for that. And it's very treatable, very easily treatable. Just doctors don't know about that. Okay, you guys, I know I'm really, really, really behind on your questions. And if I miss your question, do not take it personally. You got to understand, I talk too long and it gets lost and you have to ask it again. Do not take it personally. Hi, Angie. Any good urogynos in New Jersey? Yes, at the end of the meeting, I will do that. Debbie says Dr. Marino and Cape May County. Wonderful. Okay, you guys, I obviously missed a question on Facebook about UTI, and it's not going to let me scroll back and look at it. Facebook is so annoying sometimes. Here, let me see if I pop out my chat, if it will let me. Ooh, it might work. Hold on a second. Did that work? Oh, it did. No, it didn't. Dang it. Nope. So I can see, hello, Jill, I had a question. I'm not sure if I have UTI. Okay, I missed it. I can see the first 10 words. So if you can ask that question again, that would be great. Yes, we all associate the symptoms of frequency, urgency, pressure, pain with UTI. You just have to understand that that's the only way the bladder can tell you that there's a problem. So it only has two nerve groups. It's got the alpha afferent nerve, which control frequency, urgency, and it's got the C fiber, which controls pain. So everything feels like UTI. A bullet wound would feel like UTI. A stab wound would feel like UTI. A chemical injury would feel like UTI. Chemotherapy feels like UTI. Everything feels like UTI because that's the only way that the bladder can tell you that there's a problem is with these symptoms. Injury. Injury causes the exact same symptoms as UTI. Nan says, my IC is from pelvic floor tightness. The booster sent me back to day one, like I just threw away years worth of physical therapy. Really discouraging. Any thoughts on that? You know, Nan, it didn't affect my pelvic floor at all. Let me qualify that. I don't think my pelvic floor got tight from my booster, but it might have gotten a little bit weaker. Okay, you guys, I have no shame. I'm willing to bare my soul, bare all of my embarrassments to you. Okay, that it's okay. So I will say I've had a couple of moments where I have felt a little drop of urine like coming out of my urethra or feeling like it was going to come out of my urethra. You know, that feeling you get when you cough too hard or that feeling you get when you get startled. That's happened a couple of times since I got my booster. Normally that might happen once a month. And it's happened several times in the last 3 days, like, 3 or 4 or 5 times. So maybe that. Thank you, Donna. You're a sweetie. I know. I still owe you that phone call. Life. I'm being sick and dealing with my mom. So Nan, getting back to you listen, you already know it's muscles. If you do have muscles that are tight, you got to go right back into doing your pelvic floor relaxation. Use your heating pad. If you have vaginal Valium, use that. Do your Flexeril or any other skeletal muscle relaxants. You'll get through this. Muscles get tight when you're in pain. We cannot turn that off. This is a way our body protects us. But you have the skill already that you've learned through a year's worth of physical therapy. You're gonna have to get right back into it and do all the things you need to do to relax your pelvic floor. This is called a pelvic floor tune-up. It happens. Kayleen, I know that I missed the very first thing you wrote, honey. So Kayleen, you're a gynecologist. You're sure you have pelvic floor dysfunction? Woo! When he was doing your internal exam, I went from a pain scale of 3 to a 9. Damn. I guess my urethra and my bladder is small and my vaginal walls are touching from the inflammation. Ooh, Betty. I'm so glad you got to him. This is good. Caroline says, I got cured from IC by reading Dr. Howard Schubiner's book. Don't know anything about that. Let me take a look at it. I love success story. And you got to remember, this patient population is very diverse. We are not all the same. For some of us, it can be a central nervous system issue. For others, it could be a muscle injury, orthopedic issue, even how you're walking, if you're walking badly. Oh, this is very cool. Dr. Howard Schubiner is the founder and director of the Mind Body Medicine Center. Oh, this looks fantastic. I love it. Caroline, thank you. Thank you. Thank you for sharing this resource with us. This is all about IC subtype 5 central sensitization. How do we get the central nervous system to calm down? This looks awesome. This looks great. I'm going to save this on this thing. I want to dive into this. The more we know about mind body medicine, the better. You know, you guys, you have to understand that if a doctor says, "Hey, we really want you to try mind body medicine," you should never be offended by that. In fact, that's really very, very encouraging, because what we're trying to do is to keep your body out of fight or flight, which will intensify all of your symptoms. Remember, your brain's job is to protect you, and all it's doing is monitoring your senses. What do you see? What do you hear? What do you smell? What do you touch? That's all it's paying attention to. And then it's applying that to your history, right? And so, have you smelled this before? Is this a good smell or a bad smell? Have you tasted this before? Is this poison or is this chocolate? Have you heard this before? Is this somebody screaming their brains out, or is this somebody who's singing Christmas carols, right? And that portion of the brain, its sole job, the sympathetic nervous system, is to save our lives. So it pays attention to your senses, and when it feels like something is threatening, it puts you right into fight or flight. 14 days of untreated pain puts you right into chronic fight or flight. And unfortunately, what that then does is it massively intensifies your pain. Long-term anxiety disorder intensifies your pain. Long-term anxiety it tells us that you are stuck in fight or flight. And we need to make sure that you're not living in fight or flight. We have to calm aggressively and actively the central nervous system down, so it does not also become part of the problem. Mary says, why does my bladder hurt more after I pee? That's pelvic floor. That's your pelvic floor. Erica says, I've had waves of extreme sharp pain recently. It feels like I can feel when urine goes into my bladder. Any suggestions? Erica, that sounds like that's urethral pain. Is that your urethra? The urethra is a really interesting structure, because it can give you a agonizingly sharp pain, a sharp but quick pain, like you're going, what the hell was that? Right? This sharp pain right at the entrance to your urethra. And when we look at urethral pain, we're always going to look first at estrogen atrophy. The urethra is the canary in the coal mine when it comes to estrogen loss. You guys, you have to remember that the bladder and the urethra are the only organs in the human body designed to hold toxic waste, right? Because urine is body waste. Urine contains ammonia and urea and all sorts of other stuff. So how can the bladder and the urethra contain ammonia for hours at a time and not get damaged? Well, it turns out your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to protect the tissue. It's a barrier. We call it the mighty mucus. And it makes it hard for bacteria to infect you, and it makes it hard for any of the chemicals in your urine to reach the more fragile cells in your bladder. Unfortunately, that mucus is estrogen dependent. So when you're young and you have lots and lots of estrogen, you have lots and lots of mucus, and you can get away with stuff. When you're older, you have much less estrogen, much less mucus. If you've had hysterectomy, even at the age of 25, you're going to be a total hysterectomy. You're going to be in estrogen atrophy. You could be in chemical menopause due to endometriosis, or you could just be getting older, as we women all will do. And so what that means then is that the bladder and the urethra's ability to defend itself is now compromised. It's compromised. It does not have the structure it needs to protect the tissue. And in some cases, that's why your skin gets so dry. Estrogen atrophy. So if your urethra is screaming, the urethra is a canary in the coal mine. It will feel like there's a drop of urine stuck in your urethra that won't come out. It's really rough. It happened to me when I was 52, and I was like, what the hell is this? I threw everything I knew at this urethral pain. And you guys, you got to understand, my IC skills are pretty darn good. They're pretty darn good. I threw everything I knew at this urethral pain. Nothing worked. I threw myself on the mercy of my urologist. And here he is. I'm on the table. He's down between my legs. He's looking at me. And he goes, Jill. And I'm like, what? What? He goes, do you use the estrogen cream I prescribed for you last year? And I went, no. And he goes, why? And I said, because in my brain, I'm 25 years old. I'm not 51. And I couldn't possibly have an age related issue, which got him laughing. And he goes, yeah, I wouldn't have prescribed it for you if I hadn't seen it. It was my fault. And the challenge is that a lot of doctors just don't explain it to you. And so what did they do? They had me rub a pea-sized drop of estrogen cream right at the entrance of my urethra. Took 3 or 4 times and it went away. I have a really good blog on our website, The 7 Causes of Urethral Pain. You want to go check that out and read that too. Over on icnetwork.org. And don't forget to IC 101. It's not just a bladder disease. This also talks about the genitourinary, whoops, almost fell off. The genitourinary syndrome of menopause. Okay, so here's the deal, guys. It's the holidays. And I would like to send some IC gifts out. Little mystery boxes to some of you, if you're interested. Who knows? Maybe you'll get IC 101. Maybe you'll get something. If you would like to receive an IC Network gift box for the holidays, I need you to send me an email, icnetwork@mac.com. icnetwork@mac.com. That's M as in Mary, A as in Apple, C as in Charlie. With your mailing address. If I don't get a mailing address, I will email you something that's a gift. Okay? Okay, I need a drink. Hold on. Hold on. I got honey on my hand. Give me one quick sec here. Okay, now I have honey all over my hands. I'm drinking, you know what I'm drinking right now is I'm drinking the IC-friendly version of Medicine Balm herbal tea, which is, I have an organic mint in this combined with the Tivana peach something. I can get that for you if anybody's interested in that. All right, but I used honey in it today. Oh, so my hands are all honey now. All right, let's see here. Elizabeth, sorry, honey, I saw what you wrote about your boyfriend. You certainly do need to go to military health with that. They need to be aware that that's going on, hon. I'm so sorry. Oh, I'm getting some emails. Monica says, my bladder looks like the picture you have shown with the 100 lesions. My doctor took a biopsy in the middle of one and the pain was like torture. Oh, so Monica, did they treat the Hunner's lesions? That's the important thing. Deborah said, "You look great. Looks like you colored." Nope, this is it. This is the real me. It's just getting lighter. You know what the revenge of redheads is we never go gray. We just get blonder. So when you blondes who used to tease me are now gray, I will be blonde. But you can see that's the real color of my hair right there. And now it's all. All right. I gotta try to look a little decent here. Elizabeth says, I was diagnosed with IC 10 years ago, but just diagnosed with Hunner's lesions a few months ago, and they missed them on the first two. I guess their equipment was not advanced. That's true, Hun. There's a lot of problems with doctor training, making sure that doctors know how to identify Hunner's lesions correctly. It's pretty rough. So it's hard. I mean, medical schools have limited curriculums. And do we want to guess how much time they actually spend teaching teaching these new young doctors about how to identify a Hunner's lesion? Probably zilch. Julie says, going back for a second surgery to remove the Hunner's lesions, it's been 1.5 years since the first surgery, and I've been on cyclosporin since the first surgery for Dr. Peters in Royal Oak, Michigan. The first time I was diagnosed with the lesions in 2016, that urologist sent me down a rabbit hole of all the meds and installations, but never lasered or cauterized them. By the time Dr. Peters did the first surgery, your bladder was scarred. Yeah, honey. You know, you aren't the only one. The great news here, though, Julie, is you are in outstanding hands being a patient of Dr. Peters. Dr. Ken, there are just a handful of doctors around the country who we absolutely consider the best of the best. And so if you're in the Midwest, that's going to be Ken Peters at Royal Oak Hospital in Royal Oak, Michigan, Beaumont Health. He's the chairman of the urology department. They are the most dynamic IC research department in the United States, in my opinion. They have Dr. Michael Chancellor on staff, who also is extremely well known, among with many others. They are also playing a big role in our understanding of COVID cystitis. You've got Robert Evans at Wake Forest, who, for those of you who've been around for a while, you know that they're the ones who are growing new healthy bladders from patients' own tissue for the purpose of expanding the bladder or bladder transplant. That is called bladder regeneration. We did the announcement for that about a month ago, that he was looking for an IC patient with a very low bladder capacity, where they were going to take tissue samples from that bladder, grow out new cells in a lab, and create artificially new bladder tissue from a patient's own cells. And then they were going to transplant those to increase bladder capacity. So, and Robert Evans has been working with IC patients his entire career, 30 plus years. He absolutely loves his work. Out here on also in New York, you've got Robert Moldwin up in Long Island. He runs a pelvic pain clinic at Long Island Jewish something. Anyway, you can find his information on our website. He's the author of the original book, The IC Survival Guide. Out here on the West Coast, our pickings are getting pretty slim. Dr. Christopher Payne at Vista Urology, who was our go-to, is now retired. His last day is the last day of this month. Dr. Phil Hanno at Stanford is retiring in April. So our pickings are getting very slim out here on the West Coast. We need that new next generation of doctors who really love IC to step up and help us. Whoa, 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 wait, what the hell? Wait. Are you saying that they biopsied your Hunner's lesions while you were awake? What? Allow me to close my mouth. Wow. If you look at the American Urology Association guidelines for IC, they specifically say that hydrodistension should always be done in the operating room under anesthesia as an outpatient procedure. I'm shocked that anybody would do a biopsy during a cysto in the office without anesthesia. They better damn well have given you pain care. Holy crap. It breaks my heart. Guys, we're you got to understand that before you let anybody do something to your bladder, they need to tell you what they're doing. So before you get yourself up in the table and you put your legs in the stirrups or whatever, you need to look that doctor in the eye and say, all right, before you do this, I need you to tell me what you intend to do here. And the doctor is going to say, well, I'm going to look at your bladder. And you're going to say, okay, how are you going to do it? And what are you going to do? He goes, well, I'm going to numb your urethra and stick the cystoscope in. It's like, okay. You going to do anything else? And if the doctor says no, then that sounds good. But if the doctor says, yeah, I think I might want to take a biopsy, you're going to say, hold on. Wouldn't that be better done with some anesthesia? And if he says, oh, you'll be fine, I do it all the time, you're going to say, well, I'm not just every patient. I'm not interested in having you take a chunk out of my bladder without some pain care. Are you willing to numb the area first? Are you willing to give me a rescue installation, perhaps? I don't know, but maybe that's not appropriate. We don't want to do some installations before a biopsy because maybe that could cause medicine to go where it's supposed to go. I don't know. But I'll tell you one thing. Nobody's taking a piece of my bladder out unless I'm asleep. That's crazy. I'm so sorry. I'm telling you, we have been through some crap. Yes, we have. I think you can tell I'm feeling a little spunky today. It is what it is. Melissa said, I've had IC for 5 years, just had my third cysto. Doctor notes extensive and significant glum relations. All right, so honey, again, if you have Hunner's lesions, they should have been treated. So have they been treated? Susan said, and so again, lesions are treated through 3 ways. Cauters, they can laser them, they can cauterize them with something called fulguration, or they can inject them with a steroid or hyperbaric oxygen therapy. That's it. There's no evidence that Hunner's lesions respond to bladder installations or things like that. And you can find that the American Urology Association IC guidelines. All the research is right there. Back in 2018, Susan said, my primary care doctor sent me to an orthopedic doctor because when he ordered a CT scan, it showed a vascular necrosis of the left femoral hip joint. I Googled that and it basically said you had no blood flow going through my left femoral hip joint. But the orthopedic doctor said that was not causing my pain. I saw Dr. Evans 2 weeks ago, and he's going to take out my current bladder stimulator and put in an updated MRI compatible one. He also put in a call to my pain doctor to discuss taking out my dorsal root ganglion stimulator. My pain doctor told me that he could go ahead and remove it. He also faxed a prescription for B&O suppositories. Well, hun, Susan, I mean, like, here's the deal. I mean, you have got to, when you go, okay, you saw Dr. Evans 2 weeks ago. What did he say about your hip? What did he say about it? You know, the influences of a bad hip on the pelvic cavity and on the pelvis can be substantial. You know, my nose has been all itchy today. I don't know why. Jessica says, I have lower back pain and my right groin hurts. Not sure if it's a UTI again. Asking again. Your right groin hurts? I don't know why you would think that that would be a UTI. I mean, the classic symptom of somebody with a UTI is your urethra burns when you're peeing. I mean, the lower back pain, that can go a bunch of different ways. That can go from pelvic floor, a psoas muscle spasm. It could be kidney pain. I can't say that we can link that positively to a UTI. And your right groin, Kayleen says, I got my 8th UTI. I think I'll be getting a referral to the infectious disease doctor. My vulvodynia is kicking my butt. Went to the urogynecologist this past Wednesday. And while he was working on me, I had the ring of fire feeling. Ooh, did you tell him? And what did he say about that? Betsa said I had COVID like 45 days ago, and that can that still affect the bladder because I've had recurrent bladder infection, and yes, I have cystitis and pelvic pain, but that was just before COVID. And the answer is yeah, it could. That inflammatory reaction is real. That cytokine storm is real. And so what we know about COVID cystitis is that it can last for months, 4 or 5, 6 months. It takes a long time for that cytokine storm to calm down. You know, and then of course we have the new variants, which open up whole new doors for infection. So Judy said, my doctor said infection can hide in a biofilm that causes reinfection. She sent my urine to microgen. Good. So biofilms are really interesting. If I could go back to grad school, I would love to go back into microbiology instead of chemistry and pharmacology, because biofilms are fascinating. Biofilms are colonies of bacteria that live together, that exude this very thick, waxy coating that is impenetrable. Antibiotics cannot get through it. And so, and the biofilms are fascinating because they're like little cities, and the bacteria in them are organized in very, very specific way, with some bacteria in the center, some midway, some, and it's extremely organized. And so all the bacteria inside the biofilm reside on the same food, or anyway, they consume the food that is available in the biofilm, whatever that might be. And then the biofilm breaks up. They go out on their merry way, and then they reconvene under another biofilm. So biofilms are everywhere. We have biofilms in our body, and there's no doubt about it. Biofilms are in the streams. Biofilms are in the dentist's office and the water thing, which is why they don't want you to use water fountains anymore. They usually give you a cup of water. Biofilms are in swimming pools. They're just everywhere. Joan says, I keep getting UTIs and leakage. Even when the UTI is gone, you have some discomfort when urinating. So, Joan, again, you have to look for women of a certain age. If you find that you keep getting recurring UTI over and over and over again, we always have to look at the quality and health of your skin, also known as estrogen atrophy. It's very common for women postmenopausally to struggle with recurring UTIs because you don't have that nice thick coating of mucus that used to be a barrier that prevented bacteria from infecting you. Now you don't have that prevention. And so recurring UTIs happen in a group of women. Generally, what the research shows that about 24 hours before the bacteria arrives in the bladder, it's living quite happily in the vagina. And that led the researchers to ask, why has the vagina become a safe haven? And the answer goes right back to estrogen atrophy. So we call this genitourinary syndrome of menopause. It's not a disease. There's no disease happening in these patients. It's just your skin can't defend itself. The organs cannot defend themselves. So, normally, if you are of a certain age getting recurring UTI, then they're always going to give you a topical estrogen to use vaginally to try to improve your vaginal defenses. We want to get rid of that safe haven for that bacteria in your vagina. And so, if they're not giving you vaginal estrogen, you really want to ask why. Shannon says, what are your thoughts on bladder installations? I get them every 4 weeks. Well, what are you getting, hun? There's lots of different types of bladder installs. You getting a rescue? What are you getting? Joan says, what topical estrogen? Well, estradiol is usually the one that's happening. EJ said, you went into estrogen atrophy at 20. It took 15 years for some. Oh my God. 15 years for somebody to suggest it to you? Well, that's just cruel. Wow. Are you kidding me? They even operated on your urethra and nobody considered estrogen atrophy? Wow. Jess says, what is your opinion on trichonitis? How can it be treated? So trichonitis is very interesting. The trigone is a very specific part of your bladder that goes from where your ureters enter your bladder to your urethra. And it's distinctive from other parts of the bladder. And the trigone can have what we call in research a cobblestone like appearance. It might not be smooth, it might have little bumps on it. And for many, many years, people thought these bumps were abnormal. And so they lasered them off. But the last time I did research into that, and I will admit it's probably been 10 years, there was a general consensus that this, quote, cobblestone-like appearance on the trigone was normal. That for some of us, it's smooth, and for others, it's like, the bumpy skin right here. So anyway, with trichonitis, and let's just say here you're having the symptoms of frequency, urgency, pressure, pain, then we want to look first at, is there something that you're doing on a daily basis that is really irritating your bladder, like drinking coffee or soda? The bladder is generally injured most commonly by chemicals of some way. And so this is going to be ketamine. It's going to be high levels of acid, chemotherapy, things like that. Monica says, I'm getting bladder tissue burned in February. My urologist did not call it Hunter's lesions. You get Iolaril installations every week, but it does not help now. Steroids help. She asks, is it a good or a bad idea to remove the bladder? Bladder removal is the last step in treatment, and the anytime we're really going to be thinking about bladder removal is somebody who's failed every single therapy and their bladder has shrunken down to the size of a walnut. They have no bladder capacity at all. That's really the only time when we're really going to be thinking bladder removal. And it happens. We have a bladder removal support board over on our website run by an IC patient who did have her bladder removed. Fabulous, fabulous. advocate. But it's a hard surgery. It's a year recovery. You need a lot of help, and when you have your bladder removed, you might end up with a stoma with a bag, or if not that, you're going to need catheters. And then it's about, will the insurance pay for the catheters? Will you get as much as you need? I had one patient here in my group who they would only give her 3 bags a day, but but she needed like 6 and they refused to give it to her. So it kind of opens up a whole nother can of worms. We want to try to figure out what the effing problem is. Cause versus effect here. The fact that you have Hunner's lesions is important. Let's treat the Hunner's lesions and see what happens. I think it'd also be very, very interesting, Monica, to see if there's any chance that you might have a viral infection in your bladder. Polyoma has now been proven in multiple studies in Europe to be common in IC patients who have Hunner's lesions. And we have US research studies that support that. Because if it is a virus, then they could give you an antiviral therapy. Carrie says, who is someone near Utah? You'll have to go to our database on our website. Another Norwegian. Yes, I have relatives in Drummond. I am the second generation. All of my ancestors are Norwegian and Swedish, all of them, both sides. Are Hunner's and Blum relations the same? Absolutely not. Blum relations happen when you stretch the bladder. Hunner's lesions are profound wounds to the bladder. Angie said, is it not normal to fill and expand the bladder in an office cystoscopy? I've had it done twice. The last time she put 600 cc's. No, that is not normal to be done in the office. Hydrodistensions are not meant to be done in the office anymore. The AUA guidelines specifically say, think about it. The worst thing you can do to a closed organ is stretch it. Like literally the most painful thing you can do to a bladder is to stretch it. This is why the American Urology Association says it should be done as an outpatient procedure with you asleep. So it is not normal to do that in an office. And I personally think it's a bit cruel. Now, a lot of us have gone through this. I had a radiologist do a hydrodistension, well, she got fired. She refused to follow the urologist's instruction and overfilled my bladder massively. And I was a screaming lunatic. So yeah, that's how I feel about that. Susan said, he tried to tell me the same thing that the orthopedic doctor said. That's not what is causing my pain. Well, here's the thing about Robert Evanson. I think he's extremely trustworthy. He has voted Doctor of the Year every single time we've done Doctor of the Year awards. Every single year. His patients love him. His peers respect him tremendously. He's funded by the National Institutes of Health. He's doing cutting edge work. He's got incredible history and context. So if he does not think that that's causing your pain, then I think that you got to take him for the expertise that he's giving you. But that doesn't mean that you can't dive into the research and try to prove them wrong. Call me. We should talk about that if you want. I'd be happy to see if we can find any research studies that might convince them to look again at that. Sheila says, I've had IC for 14 years, seen 7 to 8 urologists and many procedures, including InterStim twice. I found a gyno that specializes in pelvic floor dysfunction. The med he prescribed last week has been life-changing. Well, what do you know? I've been experiencing bowel issues, but the bladder pain is minimal to none. I'm blown away. What was the medicine they gave you, hon? Sounds like it was a muscle relaxant. Okay, Shannon, getting back to Shannon's question about bladder installations, she's getting a DMSO with triamcinolone, which is an old school installation. DMSO is a little bit more controversial now because of the side effects. So historically, the old bladder installations were what we call bladder strippers, fluorpactin and silver nitrate. They're not even mentioned anymore as treatments for IC. So we don't do those anymore. Then DMSO was approved in the 1960s, I think. They once thought, so the history of DMSO is very interesting. They really thought it was going to be a wonder drug. And it was researchers who were trying to find a way to, oh my God, you live in Drummond? Monica, we got to talk. Oh, that's so cool. Okay, so anyway, let me get back to DMSO. They were looking for a way to transport kidneys for transplant. So they were taking a kidney from one hospital and trying to get it, 100 miles away to another. How do we transplant that safely and we not damage the kidney? Well, what they used to do was freeze it. But the problem, of course, is ice crystals damage the tissue. And that is how they discovered DMSO, which in fact is a byproduct of the paper industry. It's a waste product, for lack of a better term. And so I actually interviewed the guy who made a lot of that research and the guy who actually wrote the FDA label for DMSO once it was approved for IC. So in the end, it failed every research study for every other disease they were hoping it would help. The only medical condition that it showed marginal effectiveness was with interstitial cystitis. And so they approved it, FDA approved it based upon that. Our challenge, though, with DMSO is it has so many methods of action, we really don't know all the things that it does. This is what we do know. It can penetrate deeply into tissue, and it can cause a garlic-like smell. And it can cause pain and discomfort. I mean, I had like 8 DMSO treatments myself back in 1993. Didn't do a darn thing for me. Today, the most popular installation is not DMSO. DMSO has been on its way out for a good 15 years. The doctors have moved on instead to something called a rescue installation. Why? Because it can rescue you out of a flare. A rescue installation has lidocaine in it or marcaine in it to numb the nerves in your bladder, combined with heparin or Elmeron to coat the bladder wall. So the reason why DMSO has been on its way out is because when you have a DMSO treatment, it hurts. But when you have a rescue installation, it shouldn't hurt. It just shouldn't hurt. Monica, do you know anybody named Gunnar? Gunnar? Sheila says, naltrexone. I finally found, oh, okay. My pelvic floor therapist gave me articles to share with my primary care provider and my urologist about studies of an ADH med. Oh, that's, wow. So Sheila, what are you saying that your primary care provider and your urologist would not prescribe the naltrexone, which is not formally listed as a therapy for IC, but I'd like to learn more about your pain, hon. I would like to learn a lot more about your pain. I mean, and where it's located, what makes it worse, what makes it better, all that sort of stuff. Susan said your health insurance would not pay for 12 suppositories. You had to pay $310 out of pocket. Yep. Bessa says, what do you mean COVID cystitis? I've had COVID 45 days ago. And Maria says you have COVID and experience a flare up. Okay, so yes, so guys, we are the ones we've been doing that research for over a year now. The question was, how does COVID affect an IC patient? And I think I've got like 200 patients in the study. I don't know. We can look it up. I'd be happy to look it up. So what our small little study found was about 25% of IC patients who got COVID have no issues. They did not affect their IC at all. 75% reported that their IC symptoms got worse. And 25% of those reported that they experienced shockingly severe flares that lasted for months, like 4 to 5 to 6 months. And the question is, and all those, tried and true flare management tips were not working for these COVID patients. And now we have an understanding as to why that's happening, because we have the research now, which has found the inflammatory markers of COVID, not only in the lungs where they damage lung tissue, but in the kidneys and the bladder and the urine. Those same inflammatory marker, that inflammatory process has reached the urinary tract. And so the urinary tract is now developing that same cytokine storm that the lungs have experienced, which causes all that lung damage. It's happening down potentially in the bladders too. And again, these flares last for 4 to 5 to 6 months. And, we're trying to get more information on what you can do for that. We're building a new website, covidcystitis.org. It's actually half built. It's not live yet. So that we can give you more tips. But right now, this is so new that, we just don't have a lot of info. If you've got if you've got IC and now you feel like your symptoms have gotten worse with COVID, then you got to get right back down to the basics here. Fix your diet. Don't do anything that's going to irritate your bladder wall because it's already irritated. So you got to modify your diet massively. And then think about things that might help protect your bladder a little bit more. And so I can see potentially rescue installations maybe helping a little bit because you're numbing the nerves in the bladder and maybe coating your bladder wall. I would be looking at using some lysine because lysine interferes with viral replication. Remember, for those of us who get cold sores, we use a lysine chapstick, and that lysine makes cold sores, the herpes-driven cold sores, disappear more quickly because it interferes with viral replication. So something like that would be good. The other thing that I would think about is arginine enhances viral replication. Well, no, I think that's the right word, enhances viral replication. So if you're taking supplements that have arginine, you might want to back off on them for a while. And I would encourage you to do a little bit of reading on arginine viral studies. And so that would be does Sister Protect have arginine in it? I mean, if you're taking a supplement, look at it and see. Oh, you guys, by the way, I think today is the last day of our sale. We've been doing a huge sale in the IC Network shop. Let me take a look here and see if it was either going to be turned off last night at midnight or tonight at midnight. 10% off everything under $100, 15% off anything under $300, 20% off, whatever. I mean, so it's a big sliding scale there. Hold on a second. Let me just see if it's still on. Yes, it is still on. So if you're interested in trying, low acid coffees, chair cushions, again, we do have the supplements like the Allopath, et cetera, and the Sister Protects and all the Pre-Leaf. We do have all of those. Our wonderful sponsor, Pre-Leaf, also known as DSC Healthcare Solutions. So go on over to the IC. You can sign up. Even our memberships are discounted. Even all of our books, the IC 101 book is discounted. I think we only have 6 books left before we reprint. So get them while you can, because I'm probably not going to have them again for a month. Susan said she was doing rescues and they didn't help either. Kathy, I understand your fear about the booster. I mean, I don't think any of us, walked into that appointment a happy person. It's a shame that we are where we are right now. Jill, the reason the BCBS wouldn't pay for the 12 suppositories is because the pharmacist told me it's not FDA approved. Really? That's ridiculous. Hope says, I just stopped in to tell you that I tried Uva Ursi capsules for UTI with D-Manos and it worked. It took 10 days, 3 capsules twice a day. After 12 years with both IC and chronic UTIs, I found a natural remedy. However, it comes with risk of taking more than 14 days. Yeah. Hope, if you want to write that up, write up a little patient story, I might be able to put it in our magazine if you're willing to do that. Guys, let me just say this again. I'm offering little IC gift packs, mystery boxes from the IC network. If you would like to get a little gift box from the IC network, I'm not going to be able to tell you what's going to be in it. Could be a magazine, could be IC 101, could be a low acid coffee. You need to send me email. My email address is icnetwork@mac.com. That's M as in Mary, A as in Apple, C as in Charlie.com, because I'm a Mac lover. All of my computers are Apple computers. Susan says, I haven't received my COVID booster yet. My hubby thinks I need to take it. What were your thoughts about that again? Well, honey, I took it on Thursday. I don't regret it. Like I started off this meeting, I know that some of you trust me, and I hope that I've earned that trust. I think the number one reason for being careful right now with respect to COVID and perhaps getting the booster is to protect our loved ones. I operate from the assumption that I am having these done because I want to save the people that I love. I don't want to bring something home to the people that I love. And that is why we are not traveling. That is why we'll have no one here for Christmas but me, my parents. We will be Zooming this year. Because y'all got to understand, Omicron is much more contagious than Delta. It doesn't appear to cause as serious illness. But it's doubling in the population 1.5 every 1.5 to 3 days, according to something I read. Yeah. So I had the booster on Thursday, and I had the Pfizer booster. I've had 3 Pfizer shots. I was good for about, I had it at 1:15, and I got my first chills at like midnight. And I started shaking like a leaf. I was freezing, and my jaw started going. My jaw was out of control. Oh, everything was so weird right here. And when you've got my TMJ is really bad right now anyway, because I lost a tooth and we haven't been able to fix it, so I'm not biting right. So my TMJ is totally messed up. Anyway, so I got chills, I got fever, and then I got the headache. And the headache, I think, was really kind of the worst part of that because um, you just feel very weak and sick. I mean, you're not sick; it's your immune system, but you just feel, you know, it's like you're coming out of this really bad illness, like the day or two after, a day or two, well, just when you're starting to get better, but everything hurts and you're going really slow and you try to take a shower, but you get a little dizzy and woozy. That's what the booster feels like. As Patty says, the side effects are temporary. Absolutely. Absolutely. And the data is undeniable here, guys. The data is undeniable. This is about surviving. Kind of the anti-vaxxers are saying, well, it doesn't reduce the odds of you getting COVID. And that's not true. I was reading a paper from the state of Washington, which showed that people who were vaccinated who were unvaccinated were 5 times more likely to get infection than people who were vaccinated. So we do know it reduces the risk of you getting the infection, but it's about the intensity of it. The people who are boosted and vaccinated are going to have potentially much less severe disease. This is why the ICUs are filled with people who are unvaccinated. Just yesterday or 2 days ago, that state senator from the state of Washington, who was an anti-vaxxer, who called it all a plot, that the government was taking control out of people's lives and you shouldn't wear a mask. Well, guess what? He died of COVID because he was being an idiot. I'm sorry. He was being an idiot. This is a medical emergency here, people. Debbie said you had the Pfizer booster and no side effects. Oh, well, I had side effects, but you know what? If it's going to help save my life and save the life of my family, I'm all for it. Joan says I got a flare after my second vaccine. Joan, I don't have the data to back it up. I will tell you that I think I'm going to say, and you can go back to previous videos if you want. I'm going to say it's like 90%, 10%. I think 90% of IC patients who get vaccinated have no flares at all, but I think 10% do have a little bit of a flare when they get a vaccine. That's just a guess. Don't quote me. I'm just kind of relating that based upon the people that I've talked with. Monica, yes, please send me email, hun. Absolutely. And a few Gunnars. Awesome. Okay. Gunnar is a popular male name in Norway. Hope says it shouldn't give you a bladder flare. I drink water and took Tylenol. My bladder was fine. The Tylenol really helps with the headache. Really helps with the headache. All right, YouTube. I'm not ignoring you, YouTube. I love you too. Give me a moment. Kimberly said I had a flare after my booster. It lasted for 1 week. I had to get it though. I used my tried and true Valium suppositories, Flexeril, and Pyridium. Kim, thank you for sharing that. That's great. Jan is in Scotland. Jan, I've been watching right now the mystery Shetland. I love British mysteries and I love anything Scottish. She says, I'm in Scotland. It's terrible finding help and support. Sad that we suffer like this. So, honey, there is the Bladder Health UK, is the old Cobb Foundation, which is the whole IC group. So there is a national organization that supports patients in Scotland, and If you just Google Bladder Health UK, you will be able to get some help from them. I think their website is like bladderhealth.co.uk. It might be. Okay, so hold on a sec. I gotta hold on. There's this whole discussion thing I've missed here over on YouTube. Hold on a sec. Wait. You guys have been busy over here. Hold. Wow, look at you guys. This is great. Give me a moment here. I gotta go way back here. Mary says, how do they treat pelvic congestion syndrome? They actually, just like they treat varicose vein on your legs, it's pretty easy therapy. Erica says, I've had waves of extreme sharp pain and feels like, okay, we did that one. Mary said, why does my bladder hurt after I pee? We did that. We were really looking at the pelvic floor with that, especially if you're straining. Everybody promised me no straining in the new year. If you are straining to empty your bladder, you're only making it worse. If you're straining to have bowel movements, you're going to have hemis. The last thing we need is hemorrhoids. Can I get a hallelujah on the hemorrhoids, right? Elke said, would anybody go in for a January installation now that COVID is about to explode, says a nurse friend and pain doctor? Yeah, COVID's definitely going to explode. I know there's no doubt about that. It's going to be shocking. I'm supposed to have oral surgery on the 10th, and I truly believe it's going to get canceled. I do. I'm supposed to get a bone graft. I lost a tooth. A root canal failed, so they pulled the tooth, and it was a week before we went on lockdown, and I wasn't able to get the implant, and now I have to have a bone graft and the implant. And now, again, my jaw's all messed up because I'm biting on my right side, and this is getting weird and all that sort of stuff. So this is what I think. Literally, the safest place you can go is to a healthcare provider's office because they are the ones who understand the magnitude of this, and they're the ones who are trying to be safe. And so I think what you should do is call them and ask what safety, what safety standards they're implementing with the new Omicron, and see if you're comfortable with what they're doing. I mean, if they're having patients wait out in their car so that you're not passing each other, they weren't having patients sit in the same waiting room. Everybody was separated. I would assume that everybody on staff is wearing masks. Everybody out there, I think you should have safety glasses now when you're going to the supermarket. That's what I was using from day one because, the advantage now, at least with our supermarkets, at least here in California, is everybody's wearing masks. And so there's nobody coughing who's getting virus into the air. If you're in a situation where people are not wearing masks, what is that? I would be wearing glasses. Make sure you're wearing glasses, safety glasses, because you might have a mask on, but the virus can go through your eyes too. And so that's why they have face coverings. Oh, you know what that is? It's our smoke alarm. Oh my goodness. Whoa, what has happened here? smoke alarm's off. Can you smell it? This burn. It's black. It burns. So you have to let me toast this for you. The house is filled with smoke. Oh, goodness gracious. Oh. All right. It's like I'm caring for toddlers. My mother burned a piece of Christmas bread. It is black. The toaster is now out on the deck. Windows are open and it's freaking freezing outside. What, it stinks. Hold on, I gotta open a couple more windows. Oh, it's the fan. Oh, that got my adrenaline up. Yes. Oh, God. It's like her toast was black and she was eating it. It's like, can't you smell the smoke? And she goes, no. The house is full of smoke right now. This is hard. You guys, caring for elderly parents is really hard. Every day, it's something new. And I just told her, I said, you may not use the toaster again. You have to let me make your toast. All right, let me get back to YouTube here. Hold on. I will get my brain out of this panic mode. Hey, you know what? Let's do a little I Spy. You guys just go with me for a moment. We're going to calm down Jill's racing heart, shall we? Let's take a deep breath in and a deep breath out. Do it again. Deep breath in and a deep breath out. And see, like, there's my dad, and he's going to start closing everything. Deep breath in and a deep breath out. If you could look at anything that would put a smile on your face, what would that be? If you could look at anything in the next week that would put a smile on your face, what would that be? Gosh, what would that be for me? I would say a puppy or a kitten. That's somebody else's, because I can't care for anything else right now. My hands are very, very full right now because I have the epitome of elephants that I'm caring for. Okay, in, out. If you could hear anything that would put a smile on your face, what would that be? If you could hear anything, would it be a song? Would it be, yeah, they do, Susan. Would it be children laughing? Would it be hawks flying over? If you could hear anything that would put a smile on your face, what would that be? Close your eyes, imagine it. And for me, I think it'd be a crackling fire with some Christmas songs in the background. Okay, breathe in, breathe out. If you could smell anything that would put a smile on your face, what would that be? If you could smell anything, what would that be? Coconut. I love coconut. I love the smell of coconut. Or anything baking something, Christmas cookies. I made Norwegian sticks, Norwegian stick cookies from the 1950s. They were fabulous. Okay, breathe in, breathe out. If you could taste something that would put a smile on your face, what would that be? If you could taste anything that would put a smile on your face, what would that be? And for me, that would be anything with cardamom. So again, Christmas bread, julekaka. I hope I pronounced that correctly. I used my great grandmother's Norwegian Christmas bread recipe. Made 8 loaves last weekend. Okay, breathe in, breathe out. What could you touch that would put a smile on your face? Anything? What could you touch? Would it be, oh, I had a lovely, lovely 75-year-old woman I was working with last week, and we went through this with her. And you know what she said? She said, my husband's face. Oh, it's so sweet. My husband's face. So what could you touch that would put a smile on your face? And for me, it would definitely be petting a dog or a cat, something like that, something very, very warm and fuzzy. All right, let's do a deep breath in, deep breath out. And thank you for helping me manage the stress of elder care. All right, let's go back to YouTube because y'all having some good discussions here on YouTube. Hold on. I'm telling you. Donna says, this is the week of Christmas. This is when I have a flare. I need to remind myself to do self-care during the holiday. And you guys, our fall magazine, which just came out 2 weeks ago or 3 weeks ago, actually, has a great article in here on tips to calm your anxiety and stress during the holidays by Stacey Shannon. It's just absolutely fantastic. Toxic waistline. What do you recommend during a really bad flare? I feel like I'm having a terrible UTI when I'm in a bad flare. The burning is just unbearable. Toxic waistline. And again, I'm sorry for this late reply. Where is it burning? Where is it burning? Is it on the outside, like on your vulva? Or is it in your urethra or your vagina? Where are you burning? Because we're going to treat those very, very differently. Donna, thank you for moderating that. Much appreciated. Sleepy says, are we shipping supplements to the United Kingdom? Not now. We can't right now because of Brexit. It all messed up the VAT. we're going to try to get that fixed in the new year. We now have to register to collect VAT tax. Then we have to have the software to calculate the VAT. Then we have to submit monthly payments to the British government of your VAT. And right now, we just don't have the system to do that, hon. The best thing that you can possibly do is if you have a friend in the United States that we can send your product to, then they can send it to you as a gift, and we bypass all of this. So, Brexit really messed things up, I am sorry to say. Hey, Facebook, are you guys getting lots of stopping and starting? How's it going? Because I'm getting little notices of stream delays here for Facebook. Angel says, I was told that IC makes you bleed. That's not true. 100's lesions can bleed, but the rest of us don't bleed at all. Nick says, Nick from Australia, you just underwent a ketamine infusion to help lower my opioid intake. So far, it helps with the pain, but not the burning and chronic irritation of the bladder. Yeah, the problem, Nick, with the ketamine is that the ketamine can actually irritate your bladder. We have a website, Ketamine Cystitis, and so the volume is really important. Here, let me go get a Kleenex. Hold on. Christmas bread. Yes, it was Christmas bread. Burned it black. Okay. All right. So again, Nick, the challenge with ketamine is if you use too much ketamine, it's actually going to irritate the bladder. So there's this kind of fine line where you can only use so much to get benefit without harming the bladder. I know, I've said this before, and I'm going to be controversial. There are some people who don't like me saying that, but that's tough. This is my personal experience doing this for 28 years. I'm on the phone with patients, specifically men, almost every day. I find in our office that when I work with men, the great majority of them have a history of pelvic trauma. They were either athletes or in the military, or they had falls, or they rode bicycles or motorcycles where they sustained some sort of pelvic injury. 90%. I'm standing by that. That is my personal experience. And so as you're thinking about trying to help reduce your pain that's in your pelvis, I would really want to know, I would want to make sure that we know what's going on with your muscles and your bones and your tailbone. Have you had any history of any trauma at all, Nick? I mean, this is important because, as Dr. Christopher Payne said in his subtyping system, it is a tragedy to tell patients this is an incurable bladder disease, when for many of us, it is actually something that is curable, like a muscle issue. Angel says, my bladder may be irritated no matter what I eat or drink. It's possible. OxyContin should stop irritation and pain and stop you from going frequent. Oh, well, you know, The American Urology Association says that pain must be addressed at every appointment. The pain should be treated aggressively with a multimodal approach to therapy. In other words, um, uh, we have to address pain, not only trying to figure out what's causing the pain, but also by calming the nerves down and trying to catch the pain, or all that sort of multimodal approach to therapy. OxyContin, the challenge with OxyContin is that it's time release, and it is a very, very aggressive medication that can cause lots of other issues. Um, the thing about opiate medications that it's important for you to understand is that not all of them are the same. Some are very mild, and they only work for a couple of hours, while there are others that likes OxyContin, and then worse, fentanyl, and then there are ones above that last for very long periods of time. And back in the 1990s, when the time release fentanyls and the OxyContins were promoted, with the drug companies said they were safe. The drug companies said they did not increase the risk of addiction. Well, of course, now we know the drug companies were lying. And this is what caused the opiate crisis. And so doctors believed them. Doctors had a patient in pain. Well, let's give you this pain medicine. It's going to help. Not having a clue that the company was lying to them. And that is why the manufacturer is shut down and all this sort of stuff that's happening here. The tragedy now is that patients who were using some pain meds responsibly have been cut off. It's just again, it's a corporate thing that's happened. The AUA supports the use of opiate medication, but they just believe you should be doing more than opiates. We should be trying to address a fundamental problem. So if the pain is coming from tight pelvic floor muscles, we need to be doing pelvic floor therapy. Jill, you're in California. How cold? We were covered with ice yesterday morning. Jan says, I've had burning and frequency for 10 years and wasn't diagnosed due to having a healthy bladder. Most recently had a postmenopausal vaginal bleed and now need a biopsy. Interesting. Lisa says, Jan, you can still have IC with a healthy bladder. Have you had a pelvic floor? Yeah, guys, you got to remember the word IC is kind of almost irrelevant right now. In Europe, interstitial cystitis is the diagnosis given to patients with Hunner's lesions. The rest of us have a bladder or pelvic pain syndrome. So think of it as a pelvic pain syndrome. If you have a healthy bladder, but you still have symptoms, then listen, you have a healthy bladder. You got to look beyond the bladder. We have to look at other things which are going to influence the bladder, like muscles, nerves, et cetera, et cetera. Whew, gosh, we're still dealing with this smoke here. Jen says, I've had burning frequency for 10 years. Most recently had the postmenopausal bladder, but you had a hysterectomy. Oh, wait a second. No, Angel had the hysterectomy. So the thing about the hysterectomy is that the hysterectomy is also a traumatic procedure, and you could end up with a legacy of muscle tension, trigger points, scar tissue, adhesions from hysterectomy. Hysterectomies are well known to have, a potential long-term effects. I had a hysterectomy 4 years ago, and I can't believe it'd be 5 years next year. I still get levator antispasms from my hysterectomy. It feels like There's a hand up my vagina grabbing onto tissue and trying to pull it out of my body. That only happened after my hysterectomy. So Jen said, your bladder looks healthy. You're unable to hold urine. It burns. Huh. Oh, Jan, I'd love to talk to you next week if you'd like to call. You guys, Mondays are my day off. I'm going to be catching up anyway, but Roma says, hi, Jill. If my IC is hormone related, do I still need to follow the IC diet? Yeah. Yeah. You got to create an environment that will support tissue healing. Susan says she's got grandchildren coming tomorrow. We're not, the grandchildren and the great grandchildren are not coming because they've had too many outside contacts recently in the last week. And so, yeah, we're not going to let them come. Families flew. So, what can I say about Detrol for overactive bladder? I'm still not diagnosed since my urologist appointment is in March. My gynecologist treating me is overactive bladder. Also, he said I have a rectocele prolapse, but that should not have caused the feeling of fullness or heaviness in your bladder. Is Detrol a safe medication? So Detrol is an anticholinergic, just like Ditropan, just like Elavil. And so what we do know is if you take anticholinergics every day for 3 years, there is an increased risk of dementia. So it's now on our, Datrol and Ditropan are antispasmodics. The advantage of an antispasmodic is if you're having bladder spasms. So if as the last drops of urine are coming out of your bladder and you just go into the spasm, that's where they help. And so for the few times that I've had bladder spasms, I that's when I took it. I didn't take it every day. I take that back. My first year, they gave me Ditropan for 3 months. And what happened over time is it just got harder and harder to pee. It was just kind of deadening the muscle, deadening, and that's what it was doing. It was deadening the nerves to control how you urinate. And so that's why taking an antispasmodic every day is kind of counterintuitive and counterproductive for somebody who has to pee a lot because their bladder wall sensitive, because it actually kind of makes it a little bit harder for you to urinate. And so, at least for me, I only took the antispasmodic if I was having bladder spasms, and that only happened a couple of times. It only happened a couple of times, okay? So that would be one thing. The difference between overactive bladder and IC is in the sensation of urgency. If you're running to the bathroom because you feel like you're going to leak and be incontinent, then that's overactive bladder. If you're running to the bathroom because you're trying to reduce pain, then that's bladder pain syndrome, interstitial cystitis. That is a defining characteristic, is that sensation of urgency. If you're running to the bathroom because you feel like you're going to leak, that's overactive bladder. If you're running to the bathroom to reduce pain, that is interstitial cystitis. In the meantime, he's put you on estrogen and you're doing pelvic floor. Good. Excellent. For all we know, this is just the genitourinary syndrome of menopause for you, Jean. You need to Google that, genitourinary syndrome of menopause. Look at the symptoms, see if that matches. Anne says, I have to go to the dentist, long appointment. Hope I don't get a flare from stress. Yips. Susan said, how do we get the magazine? Is it monthly? It's not monthly, it's quarterly. And you just become a member of the IC network. So just going over to the IC network, icnetwork.org, and go into our shop and go to members. It's $25 a year if you want to read it electronically, $50 a year if you want us to mail it to you. Plus, you get a lot of back issues of our magazine that in your member page that you can download anytime. And then there's even a $100 prescription where you also get the IC Chef Cookbook, 5 years worth of back issues, all sorts of stuff. Kathy says, I'm urinating pink. I have Hunter's lesions. It hurts so much. Honey, if you're urinating pink, you need to call your doctor. That's not normal. That means that you're bleeding. And they need to figure out why you're urinating pink. You either have a UTI or you have lesions that are bleeding. I think you need to call your doctor like right away, like even this afternoon, or go to urgent care and let them know because you could have a UTI. John says, can tight pelvic muscles cause permanent nerve damage over time? I think it can. We call that neuralgia. I think it's possible. I mean, as I try to understand my own issues with my pelvic floor, I mean, I do believe that some of the nerve stuff I have going on down there is there. It's very hard for nerves to be healthy if they don't have good blood supply. Nerves require blood supply to function. If they don't have good blood supply, they're not going to function, and you're going to end up in a poor situation. Ann says, can you have OAB and IC together? No, I don't believe so. David said, did you get my email about my magazines? No. But I haven't read my email for like 3 days because I was not feeling well. Let me David, the last email I have from you is from June under one address. Maybe it was from a different email address. Go ahead and resend. Oh, Roma says, let's see. Roma's in Ireland. Not much known about IC here. Diagnosed via cystoscopy as my bladder was inflamed. Your website's been helpful. I'm so glad, hon. I'm so glad. Now I know I've missed questions. I know I have, especially on Facebook. Please ask them again if I missed your question, okay? No shame. And says, how do you treat vaginal burning? Well, with vaginal burning, if it's from estrogen atrophy, you're going to treat it with a topical estrogen cream, like a topical estradiol cream. If it's burning because of tight muscles, then you're going to be doing things that are going to relax muscles. So you're going to use heat, or you're going to use vaginal Valium, something like that, or Flexeril or Baclofen, a skeletal muscle relaxant. So generally that's Baclofen or Flexeril or Valium. Wait, hold on. Baclofen is a non-sedating skeletal muscle relaxant. And then Flexeril, also known as cyclobenzaprine, has a sedating effect. So you really only take that at night. You can't drive with that. That's what I take. I take a quarter of a Flexeril every night at this point. Or you can do oral Valium. Hey, I can't believe Facebook's actually working. You guys, Facebook has been driving me crazy for months. Let me just look. I want to look something up here. Hold on. Give me a sec. So with the low dose naltrexone, I wanted to come back to that. Low dose naltrexone has a current, see, it kind of triggered my memory here. There is a clinical trial right now that started in March with low dose naltrexone. The goal of the study is to see how much pain improves. It's the IC pain trial. And they expect to be done by June. And it was done at the North Shore University Center for Pelvic Health in Skokie, Illinois. That's exciting. Can't wait to see that data. That'll be great. The more we can help pain, the better. And of course, hopefully you all know about PEA, palmitoethanolamide. PEA has been used in Europe for about 2 decades now for a wide variety of pain conditions, from fibromyalgia to burning mouth syndrome to, in fact, interstitial cystitis. 2 years ago, the European researchers brought an IC study to the American Urology Association meeting in which they showed that IC patients responded beautifully to PEA with no shown side effects. By month 3, 87% of IC patients in their study showed a significant reduction in their pain. And by month 6, 25% were now completely pain-free. PEA is known as palmitoyl ethanolamide. It has been studied extensively, many research studies, dozens and dozens and dozens of research studies, extremely well tolerated. And that's something for anybody struggling with pain you might want to consider looking at. This is, I asked, because you can't get that European formula here in the United States. And so I asked Natural Approach Nutrition to look at the study and see if they could create something similar to what was in that study. And that is Peora, Peaora. And this is specifically for pain to see if it might help calm nerves down. So a lot of people ask me, what do I take? And this is what I take. I'm IC subtype 3, pelvic floor IC subtype 5, central sensitization. My nervous system is extremely sensitive now. And I'm characterized by having extremely sensitive skin, as well as a sensitive sense of smell, etc. And I always know my central nervous system is getting worked up when I start getting pinpricks in my skin. I would just get random pinpricking sensations. It's like you're chasing dry skin with lotion trying to fall asleep. And sometimes I couldn't sleep. I mean, I just had pinpricks all over my body. As soon as I started taking this, that stopped. And I might have one or two pinpricks a week. And so I love the Peora myself personally. The general consensus among the researchers is that palmitoyl ethanolamide is the most effective for neuropathic nerve-driven pain. And for those of you who are in Ireland and in Europe, you don't have to get that from us. It's already well known over there. Let me type it because I want you to. All right, so oh, you guys on YouTube, I have you on slow mode. Donna says Pure is great. You can only write something every minute, and that was to discourage anybody who tried to come in to stop the meeting. I'm hoping that helps. One post every minute. Tyler says, I will have a thicker and smaller bladder from the damage of IC over the years. Maybe when I'm 50, I'm 34 now. Have you heard of this? Is it dangerous? Will they need to remove my bladder? Tyler, well, I'd sure love to see him explain the method of action as to why that happens. Now, listen, if you, for example, have had a lot of recurring UTIs, like constant recurring UTI, what happens is the infection begins to damage the bladder wall and you end up with scar tissue. Or if, for example, you've had many, many Hunner's lesions and they laser them off or they cauterize them off, wherever that cauterization happened, you get scar tissue. And the challenge with that scar tissue is that it does not expand. So scar tissue limits bladder capacity. The bladder just can't expand like it normally would. Because remember, your bladder's like a balloon. It's kind of small, and then as it fills up, it stretches and stretches and stretches, and then it shrinks back down. It's fascinating how that works, actually. I think that you have a lot more control over this than you realize. Okay. It is your job to create an environment that will support tissue healing. Number one, we have to focus on cause versus effect. We need to know subtyping, right? Because not everybody's the same. We don't think of IC as an incurable bladder disease. We think of IC as a pelvic pain syndrome. Why? Because other structures in the pelvis are often involved, if not driving these symptoms. So, our reality here for guys is our first job is to try to figure out what subtype you could be. We have 5 fundamental subtypes. Subtype number 1, Hunner's lesions. Do you have lesions in your bladder? These are the big bloody wounds. These are Hunner's lesions. Okay, so Hunner's lesions are tough. This is considered the worst form of IC. These are the ones that do get cauterized. This is really the only main disease process happening in this patient population. When you biopsy a lesion, you find massive, massive inflammation. There is a biological war happening in the middle of this lesion. And now we know why it's happening, because now we have research which has linked certain viral infections. The challenge here is we think we have UTI, and when you think about UTI, you're thinking bacteria. You're not thinking about virus or fungus. But we can have a viral infection or a fungal infection in our bladder. And in fact, the Europeans found polyoma virus in patients with Hunner's lesions. And our own National Institutes of Health also confirmed that data several years later with their own viral study. And so having a viral test to see if there is active virus in your system would be useful, because then they can do antiviral therapies potentially. Here we go. Tyler says, I'm bladder wall driven from tight muscles. He doesn't see lesions. Okay. But Tyler, this is exciting. Okay, this is exciting. So he doesn't see lesions. So your bladder looks healthy, but you have tight muscles. You're not bladder wall driven, you're pelvic floor driven. You're stuck in the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved because they are so interconnected. They are so incredibly interconnected. So for some people, IC begins after a bladder wall trauma, and then the pelvic floor muscles get tight in a response to the pain, right? And so for these patients, let's say your IC began after chemotherapy and the chemicals from the chemo are just killing your bladder. Our therapeutic priority for that patient is to calm and soothe the bladder, calm the bladder down, and let's get the muscles to release. But that's the smaller group. For more people, it begins with a muscle trauma. And you don't know you have a muscle trauma. Many people don't know they have a muscle trauma. Your first symptom is frequency, urgency, pressure, pain. And generally what happens is you call the doctor, you say, hey, I think I have a UTI. The doctor goes, all right, here's some antibiotics. They don't work. You call back, you call the doctor back, say the antibiotics didn't work. The doctor says, well, let's do a urine culture. No, I'm going to explain this. I'm going to explain this. Okay, so the doctor does urinalysis and a urine culture. It comes back negative. And you're going, but it really hurts. It's got to be a UTI. And the doctor will say, yeah, here's some antibiotics, take them for 6 months, low dose. And it doesn't work. So a year later, you go back to the doctor and say, listen, I'm still stuck here. And the doctor goes, well, maybe you've got overactive bladder. Let's give you overactive bladder meds. So you do your due diligence, you're willing to do it. So you do it for 6 months or a year. You go back to the doctor. I'm not better. And the doctor gives you, oh, I hate to break it to you. You got this dreaded bladder disease called interstitial cystitis. Here's the diet. Here's Elmeron. I'll see you in 6 months. And you're like walking out of the room going, what the hell is this? But you want to get better. You want to get better. There's no doubt you want to get better. So you do everything they tell you to do. You follow the diet. You take the Elmeron, but you don't get better. And you go back to the doctor and he starts doing more aggressive therapies and they're not working. Why? Because bladder therapies don't fix this patient. Because their bladder is healthy. They sustained another problem. They have pelvic injury. Their muscles were injured. The consequences of a muscle injury are profound. We have, let me get my book here. Hold on. So let's think about a fall. Okay, a very interesting. So I had a wonderful guy call me, wonderful guy. That same exact thing happened to him. Eventually diagnosed with IC, yada, yada, yada. And I'm like, all right, take me back in time. Was there any sort of event which you think triggered all of your symptoms? He goes, yeah, I know exactly what it was. And I went, what happened? He goes, I fell. Oh, I went, okay, how'd you fall? He goes, well, I was trying to impersonate Tom Cruise in that movie where he was sliding in his socks. And so I was sliding in my socks across the floor and my feet flew out and I landed on my butt. But it was at the top of the stairs. And so I went butt first down the stairs. And that night, his symptoms began. And I said to him, I said, did you ever tell any doctor about that? And he said, no, I was too embarrassed. That was his triggering event. He suffered a compression injury. All of his weight landed, maybe on his butt in this, like an area maybe this big, right? All of his weight, his 180 pounds, or however much he weighed, bam, landed in one spot. That is a compression injury. So we know that muscles are squeezed and damaged, and a damaged muscle is a weakened muscle. We know that the blood vessels in the area are damaged because that's what causes a bruise. And we know that the nerves in the area are damaged because they too are compressed. So Dr. Jerome Weiss in this book, Breaking Through Chronic Pelvic Pain, which, Tyler, you have to get this book. You have to get this book. This is such a good book. And it's written for men and women. So he talks about compression injuries in here. So I want you to look at this. Look at these pictures here. These are trigger points. So a trigger point is a muscle knot, right? And you know that if you got a muscle knot in your back, what do? You generally have you ask somebody to push on it, because when you push on the muscle knot, it releases. Let me just explain this. Your muscle fibers they're horizontal fibers that do this, right? So this is at rest, this is compressed. And there are little fibrins that kind of anchor them here. But normally that releases and the muscles go back to their normal relaxed weight. So a trigger point is when that muscle fiber does not release. Okay, so it's just stuck here and it hurts. So let's go back to this picture for a moment. So here we have a muscle knot, and I want you to look at what it's doing to the blood supply. Do you see that? We have healthy blood supply on this side. We have very poor blood supply on this side. This picture over here is an even better picture, because if you look above this, you can see what normal blood supply looks like, right? But look at what happens after you have trigger points. We have now lost the blood supply on the other side of the trigger point. The other thing, let's see. When the muscle fiber has an extreme stretch or is traumatized, nerve endings can be injured. This causes a continual release of acetylcholine, which in turn causes the muscle fiber to go into sustained contraction and also develop a knotty texture. Normally, a muscle fiber releases calcium during a contraction. It then reabsorbs the calcium following the contraction to relax. But literally adding insult to injury, the contracted muscle fiber now lacks the metabolic energy required for calcium reabsorption. This is because the contracted fibers have compressed and narrowed tiny capillaries that supply them. Since the fibers don't have enough energy to reabsorb calcium for muscle relaxation, an imbalance develops between supply and demand, and an energy crisis occurs. So, okay. So the long-term toll of pelvic floor tension is ischemia. You get your bladder wall does not get the blood flow that it needs. The bladder wall starts to break down and becomes food sensitive. But as long as you've got pelvic floor, bladder therapies are not going to work. We have to our therapeutic priority for that group of patients is to restore blood supply, to restore circulation. So the majority of your work has to be focused on working on your muscles and working on that injury. It says, I was 11 when I first found out about pelvic pain from pain after a bowel movement. I didn't tell anyone until I was 26 because I was embarrassed, and it was also getting worse. You know, you're not the only one. I think a lot of us, you know, got oh my God, you know, again, embarrassing story 101. When I went away to college, I started developing severe pelvic pain. I went to the healthcare center and the guy goes, "Oh, do you realize that you're constipated?" I was like, no. He goes, "You are massively constipated. We call this first year, you know, he said, this is completely common in students who move away from home and go to the dorms for the first time because you're not eating well and you get constipated. And then what happens when you're constipated is you push hard to try to get it out and you strain those muscles. And that's a problem. And then strained pelvic floor muscles, it's like, oh, wait, I didn't know I had muscles down there. And all of a sudden you're tender down there. But Tyler, can you remember any trauma at all? Like, did you ride a lot of bicycles? You remember breaking a leg, breaking your tailbone, anything? Were you a football player? Were you a soccer player? Anything? Elizabeth says, I have Hunter's lesions. I'd be willing to try hyperbaric oxygen therapy. Only I'm sure insurance does not cover it for IC. I have great insurance. I do have an HSA. There appears to be 3 locations that do it in my area. Only one of them is done by a doctor. It is in a cancer center, but they will do it for people with other issues. I'm going to ask my primary care provider who I should go to. I'm sure the holistic centers that do it are less expensive. Elizabeth, if you email me, I would be happy to give you that research on hyperbaric oxygen therapy and its effectiveness for Hunner's lesions. I did an article on it. If you're a member, just go back. I think about a year ago we did that story. Tyler had a car accident in 2007. So did your symptoms begin after this? And what were your injuries in the car accident? What were those injuries? And did your symptoms start after the car accident? Oh, wow. So you had some symptoms before. So the odds are, the fact that listen, we got to be honest. Do kids eat healthy? Do they eat what mom makes for them? The answer is yeah, no, not so well. So you may have been having completely normal moments when kids get constipated. It just happens. But you sustained major injuries in your car accident to your gut. And so you had to have major bowel surgery. So that's like really important here. So again, you prove my case about men who have a history of trauma. So you have to remember the viscerosomatic. Well, oh, and you had back surgery from L1 to S5. And did you have the back surgery because of the car accident? So the legacy here, legacy number one is you had surgery. You had you had a major physical trauma in the accident itself. Then you had major surgery. And so okay, got it. So the somatovisceral reflex helps us understand what happens. And that is that when you're in pain, your muscles get tight to protect you from that pain. That is called the guarding reflex. And so that's concept number one, is that it may be that your muscles have just been stuck in massive tension since a car accident and since a surgery. That's absolutely possible. And then throw in the fact that any additional traumas will just reinforce that muscle tension. I like to think of it as it's your vulnerable point now, right? That once you sustain a major injury, that area, it's always going to be a little bit more vulnerable. It's never going to be as strong as it was before the accident. So we can understand now why your muscles are so incredibly tight. Do we know why your back was bad even before the car accident? Like, do you have scoliosis? We're not even talking about just the concept of trauma. There's a lot of, trauma affects us physically, mentally, emotionally. But what a lot of times we don't understand what trauma does to the central nervous system. That when you are in pain, if you are in pain for 14 days, your brain you go into fight or flight. Like your brain literally thinks your life is at stake. And so what happens then is that rather than normally coming out of fight or flight, I mean, think about it. Fight or flight, like if you were open to your front door, if you're open front door and you see a saber-tooth tiger across the street, you're going to immediately go into fight or flight. Your sympathetic nervous system takes over, the amygdala in the brain takes over, adrenaline starts shooting through your body. It's tightening and it's preparing you to run or fight for your life. It's tightening your muscles, it's raising your heart rate, it's raising your blood pressure. There's no cognition happening here. This is just the most primitive part of your brain taking over. But then the saber-tooth tiger walks away. The saber-tooth tiger has fled the scene. So normally you can see the saber-tooth tiger is now 5 miles away. You don't have to worry about it anymore. The parasympathetic nervous system takes over and it turns the amygdala off. And it reduces your heart rate and it reduces your blood pressure and it relaxes your muscles. And you can breathe again. You're no longer fighting for your life. You can breathe again. But what happens, what the research studies have shown for patients with chronic overlapping pain conditions, and I'm in this group, is that that's not happening for us. That our brain is stuck in fight or flight. And that's not a mental illness. And I'm not doing this to say mental illness. I'm just pointing to your brain. Okay. What's normally fight or flight turns off. Our nervous system is not turning it off. It's not a mental illness. Nobody is saying that this is a mental illness. This is called a central nervous system maladaptation. It's like the brain gets habituated to fight or flight. And what the research studies show is 14 days of intense pain will cause that chronic fight or flight or long-term fight or flight, and 20 days of bullying will do the same thing. Now, of course, we have no idea that that's happening. We're just stuck in fight or flight. And we got the anxiety disorder to match. We got the negative thoughts to match. We've got the catastrophizing to match. And that always is going to intensify pain. And so a big part of the work we do now is understanding that we have got to create an environment that supports healing in our bladder, in our muscles, but also to our central nervous system. So you say here, you think it was from lifting weights, but honestly, all of my brothers have spine issues. You had a brother with a neck fusion. You just had a neck fusion in the summer. That's very interesting, hon. That's very interesting. So musculoskeletal, musculoskeletal, musculoskeletal. Are you responding to pelvic floor work? Is it working for you? Have you even started pelvic floor work? Well, you must have, since you said that earlier. What's happening with that? Kathy says, I was in a car accident in 2012, had lots of injuries, including collapsed lungs, TBI, temporary brain injury, entire breast bruise. I feel that every day. They don't tell you that breasts are sensitive, right? Anyway, just like daily. And the seatbelt crushed your pelvic. Oh my God. You also had back surgery in 2019. Oh, honey, Kathy, wow. Well, number one, I'm so glad that you're here today, because that sounds like it was an absolutely devastating car accident. And so I'm so glad that you're here today. But, how are your symptoms now? You can't find any relief. So have you had a pelvic floor assessment? And when you say you crushed your pelvic floor, were the bones crushed? I mean, did you have any broken bones? Tyler says, I haven't done any physical therapy because it's not covered by insurance. No physical therapist near me in New York City will take insurance for pelvic floor disorder. Have you tried Beyond Basics physical therapy, Amy Stein? Beyond Basics Physical Therapy, Amy Stein, Renew Physical Therapy with Isa Herrera. So, listen, again, I have no shame. I'll talk about anything. I love success stories and I love patients who go the extra mile to get the care they need. I have one really good friend, Lisa, who is amazing. She is extremely low income. She has not been able to work in 25 years. And um, she has been able to get the great majority of her care paid for because she, number one, she asked about programs that they might have for people who might not qualify, as well as medical foundations in the area, as well as programs at local hospitals. So I say be the squeaky wheel. Now, the one thing, Tyler, is it doesn't, so like the least important part of physical therapy is actually the physical therapy appointment after the first appointment. The most important part is what you do at home. And again, this book is the bomb. And Tyler, for you, as a gift, I will send this book to you. I need you to email me, icnetwork@mac.com. I'm going to give you this book because I truly believe that this will help you and change your life. Okay? This is like a master class in pelvic injury or trauma. Kathy Jackson, I'm going to do the same thing for you, honey. I will do exactly the same thing for you. If you guys email me, icnetwork@mac.com, that's Tyler Gorland and Kathy Jackson, I will send you this book for free. Okay? Okay, I better make sure I have it in stock. Oh, wait, hold on a sec. Let me see how many copies I have. Wait. But I will get it to you somehow. Hold on. I got 17. Okay, I can do it. I can do it. Okay, so Kathy Jackson, Tyler Gorland. Tyler, email me right now while we're on so that I will see the email come through. icnetwork@mac.com. Kathy, email me, icnetwork@mac.com, so that I can highlight that email because I don't want to lose this. So for both of you, Lisette says, I'm paying out of pocket for physical therapy. Okay, so here we go. So here's the thing. If money's tight and you can't afford physical therapy, try to go at least once. Because we need a proper diagnostic evaluation of your pelvic floor. The purpose of the very first appointment is to touch muscle. They're gonna look at your feet, your legs, how you walk up and down a hallway. They're gonna look at your lower back. They're gonna look at your abdomen. All they're doing is looking for patterns of muscle tension. And again, how you walk is important. They should watch you walking to the left or down a hallway and back. Then they're going to do an internal exam. And all they're doing is touching muscle groups, right? And the challenge here is if you can see this, you can't reach these muscles from the outside. You have to touch them from the inside. And so they're going to use their finger, to try to touch these muscles as deep as possible, right? And if they can touch a muscle and reproduce the pain, this is your hallelujah moment. It's like, oh my God, that's it. What are you touching? And hopefully they will then identify what they're touching. Is it the piriformis? Is it the obturator? Is it your levator, right? So hopefully you walk out of that meeting with the name of the muscle that's compromised or the muscle groups that are compromised. Tyler, got the email? Thank you. Then what you can do is number one, this book is remarkably helpful because you got to go back to school. I mean, you got to go back to school. You got to study. You have to understand where the muscles are, where the bones are, et cetera, et cetera. Um, um, okay. This will help you navigate the hows and whys of why you've been in pain for so long. And the chapters at the end about what bikes do to the pelvic floor, rectal pain, perineal pain, tailbone pain. Oh, I mean, it's a love letter to patients, how it causes urinary issues, all this sorts of things, all these sorts of things. So useful. Then you can go on over to YouTube, and there are tons of physical therapists now who have their pelvic floor program online, but you have to search by the muscle group. And anybody who tells you a Kegel exercise is what you do, they're wrong. You do not do Kegels unless you have incontinence. If you have incontinence, then we potentially have damaged muscles and nerves. So, Tyler, getting back to you, if there's any way, even if there's no program, if there's any way that you can save up and just go that first time with somebody really good, like Amy Stein at Beyond Basics Physical Therapy or Isa Herrera at Renew Physical Therapy, they've both written books on pelvic pain. So that, and again, your objective there is to get them to study your body and give you the names of the groups that are messed up and then give you exercises. And then you just have to be perfectly honest with them and say, listen, I can't afford to do this every month, but I might be able to come back in 6 months. Can you give me some exercises that I can do in the meantime that might help? And Lisette says here, so I'm paying out of pocket for physical therapy for almost 12 weeks now and not sure it's helping. How long does it usually take to see results? It depends on how long you've had muscle tension and why you have muscle tension. So for me, it probably took the first time. How long would that have taken? I'm going to say like about how long you've done it before I started feeling a difference, but it's very subtle. Thank you, Kathy. I got yours too. Great. Thank you. Let me just make a note to myself. All right, hold on a sec. Tyler and Corlin. Kathy Jackson. Okay. So, Lisette, I didn't really understand or see that I was getting better until I learned how to do internal massage. That's when I could completely tell if my muscles were good or bad. And that's what I do now because I still get, you can hurt your pelvic floor just by straining. If you get constipated, you push too hard, you can put yourself right back into pelvic floor tension. So, like, so again, pelvic cavity, right? And using a wand allows you to follow the length of the muscle fully, and it gives you a lot more room to go. So if you can see here, I am now using a wand. And so what's really interesting when I do my pelvic floor work is that I can feel when my muscles are tight versus when they're when they're normal. When they're normal, this whole area is flat. It's sitting there, it's flat, it's loose, it's comfortable, it's not tender at all, right? I tend to have more pain on my right side right now, and I'll tell you where my pain is. Let's see. The bulk of my pelvic floor pain right now, here's my tailbone, here's my hip bone. I tend to get a lot of rectal sensitivity. And it's this muscle group right here where I have to do the bulk of my work. And this really just comes from sitting too long. Like it's vibrating right now. I've hit that moment where my muscle is saying you're sitting too long. And so again, I use my wand to get in here from my tailbone to the side bone. And I'm just trying to it gets hard and lumpy and very tender to touch. And it's interesting. I can just do this for like 2 minutes and I can get it to release and relax. And so that's my long-term issue with me and what I do. Now, in this book, one of the mysteries that Dr. Weiss tackled in this book was, why do some patients always stay in tension? So they'd come to his clinic, he'd massage the muscles, get them back into normal muscle health. But a week later, a month later, 2 months later, that patient came back with the same tight muscle in exactly the same location. The trigger point was back in exactly the same location. Why? That's what he wanted to know. Why did the tension always come back? And that's when he went from the muscle to looking at what puts stress on muscles. Bones. So it makes sense that if you have a bad hip, for example, and you're limping, you're walking like that. Like one hip, your hips are supposed to be level. One shouldn't be higher than the other. So that makes sense. The health of your SI joint. So here's the SI joint. Here's your SI joint. That's my problem, is my SI joint on my left side. My SI joint is way too flexible. It's keeping my muscles in tension. If you have a bad knee and you're limping, it's a problem. Hold on. The 99-year-old is walking into the room. He's giving me a list of jokes. Do you want me to tell these jokes online?
If you feel like it.
Okay. Thank you, Dad. Ah, that's pretty cute. Okay. So if you have a bad knee that has you limping, bam, okay. But here's the chapter that blew everybody away. The feet. He finally partnered with a podiatrist. He was trying to understand if the feet could cause pelvic issues. And here's what he found. 95% of the patients who had long-term chronic pelvic floor tension were not walking normally. They were not walking normally. They had shin splints or plantar fasciitis, or they had an ankle that rolled in or out, or they were duck-footed where your feet are like this, or pigeon-toed where their feet are like this. And that the missing piece of the puzzle for the great majority of those patients who were in long-term chronic pelvic floor tension was to fix how they were walking. And I want you to look at this picture here. This is a very, very important picture. Let me find it. God, this book is beat up. I love this book. Let me just, here's another picture. You want to know what riding a bicycle does? That's what riding a bicycle does. It pushes up right against nerves. which is why we have pudendal neuralgia, also known as bike rider syndrome, in patients. But anyway, listen, I want you to look at, okay, I show this picture all the time. It's hard here. Hold on a sec. I have to lower it. Okay. So here is the normal leg. We have a normal ankle. And I want you to see that the lower leg bone is basically at a 90-degree angle from the ground. And the normal forces go straight up, basically 90 degrees, to the hips and the pelvis. And this is what a normal pelvic floor looks like. I mean, a normal muscle position. Okay, let's go back. And now let's look at somebody who has an ankle that rolls inward. Immediately, we've lost the 90-degree angle. Their lower leg bone is now going outwards. Look at what it does to the knee. And look what it does. It redirects the forces and pressures up the leg, eventually up to the top of the femur, into the pelvic floor. And if you compare the side, you can see that the pelvic floor on this side, the pelvic muscles on this side, are stretched out of position. It puts a lot more tension and pressure on the pelvic floor when you walk with an ankle that's rolling in. What do you think of that? There's also something called Morton's toe. If your second toe bone is longer than your first toe bone, okay, so here's the issue. So you see how the second toe is much longer than the big toe? And specifically, we're looking at this bone right here. So the way the human body bones are built is the bigger the bone, the more weight it's meant to carry. So in your foot, it is your big toe that is meant to carry your weight when you walk. However, if you have Morton's toe, it is your second toe which hits the ground first. So instead of this toe carrying 60% of the weight, I don't remember what the exact statistics were, but generally in a normal foot, these two bones carry all your weight and your other bones really aren't that involved. But if you have Morton's toe, your second toe takes the majority of the weight. This is now not carrying hardly any weight. And then the smaller toes out here are carrying much more weight. And that's when you start to get your toes bending down because they're trying to grip the surface. They're trying to do something that they really aren't meant to do. It's the big toe and the second toe that are meant to carry your weight. And so Morton's toe is also a way that your pelvic floor can be messed up. And the cool thing about this is really easily fixable. We had somebody, when this first book came out, I had everybody in the meeting take off their shoes and look at their feet. You can just put a little tiny cushion underneath this knuckle, underneath the knuckle right here, to force it so that this carries your weight first, and that basically resolves the problem. So Breaking Through Chronic Pelvic Pain is an insanely good book. All right. Almost dropped that. Let's see what the 99-year-old wanted to contribute to the meeting. How does an attorney sleep? First he lies on one side and then he lies on the other side. Ooh, snap. How do you make holy water? You boil the hell out of it. Two windmills are standing in a wind farm. One asks, "What's your favorite kind of music?" The other one says, "I'm a big metal fan." You know what my dad discovered last week, a couple days ago? The knack. My Sharona. Like my dad discovered that on Amazon Music and was playing My Sharona in our kitchen really loudly. He loved it. He was like, he's a 99-year-old. It was hysterical. Let's see. Is it ignorance or apathy that's destroying the world today? I don't know and don't really care. Yeah, there you go. He's pretty funny. Selena says, "What does pelvic floor physical therapy help with? Does it help with frequent urination?" Yes, it does help with frequent urination. Pelvic floor physical therapy is all about restoring blood supply. It's very hard for things to be healthy if they don't have good blood supply down there. That's a number one goal with pelvic floor physical therapy is to get your muscles healthy, relaxed, so that they're not impeding nerves and blood vessels. And once you restore proper circulation down there, then the bladder wall has an opportunity to be nourished, to receive oxygenation, nutrition. It should then reduce neuroinflammation because we're now restoring blood supply to nerves, and hopefully it will calm a lot of things down. Lisette says, "My physical therapist says my tight muscles are causing pudendal neuralgia. My worst nerve pain is in the urethra clitoral area." That's absolutely common. Absolutely common. And so all the more reason why you need to be doing physical therapy so we can get those muscles calm again. Now, Dr. Weiss in his book believes, here, hold on. He believes a lot more people have pudendal neuralgia than he realized. So he talks a lot about how he evaluated patients. Other signs of pudendal neuralgia are pins and needles or areas of numbness on your skin, as well as obviously PGAT, things like that. And so I have a couple of areas where I've had pudendal neuralgia. I have a little area of pudendal neuralgia about an inch to the left of my rectum. And they tried nerve blocks a couple times, just couldn't hit it. And it's all about sitting too long. And then I had a very weird pudendal neuralgia, which was actually pinpricks along my pubic hairline. They thought it was yeast, then they thought it was eczema. And then finally, 4 months later, they went, "Oh no, didn't you know that this is tight muscle squeezing the nerve that's..." I had no idea pudendal neuralgia could manifest as pain on the vulva in that way along the hairline. I mean, kind of far away, but it was. And so what they did is they gave me a topical estrogen lidocaine jelly to use to calm the nerves in the skin and sent me back to physical therapy. And it was the two things that made it go away. So Lisette, have they given you anything to use on your skin while you're doing the physical therapy? Okay, but what about calming the nerves down? Have they given you anything for the nerves? I mean, this book would be wouldn't be a bad book for you either, hun. It wouldn't. Let's see if I can get to that section on that. The only thing this book doesn't have that I wish it had is an index. You know, he was very old when he finished it, and I just don't think they wanted to get it out. Books kind of go. I mean, books can be in production for years. Okay, so your urologist prescribed gabapentin. Are you using it? And you have the book. Great. So what about a topical? I mean, have you found that using a topical lidocaine like Anacream, has that made any difference in your urethral pain to try to get those nerves to calm down a little bit? Talk to your urologist about it. Anacream, Anecream, is over the counter. I use it for hemorrhoids. Let me get it. Here, hold on. Anacream. It's kind of shiny. So this is an over-the-counter lidocaine that it's 5% lidocaine that is really good. I mean, like for hemorrhoids, it will keep that area numb for like an hour, 2 hours. Why didn't you talk to him about using something topical just out of curiosity? Now, you guys, y'all know I cannot give you medical advice. I am not your doctor. My job is to open new doors, give you new questions that you can ask your doctor, right? That's my only job here, is to educate you, empower you, and kick you in the butt and get you back to the doctor with different questions to ask. You have the book. Lisette, you have the book. You need to reread the section on this. Okay, reread the section on this. Because he was very clear about having to have making sure that we have a way of calming those nerves that are already worked up, the nerves in the skin. Wow, I've gone a lot longer today than I thought I would be able to, considering where I started this morning. Selena says, have you ever had to ask for accommodations for IC? Yeah, we've written. I have a disability resource center over on our website. It's kind of tricky. It's tricky because you know, under the law, under the Americans with Disabilities Act, you are required. I mean, it is a law that if you work for an employer who has, I think, either 25 or 50 employees or more, they are required to implement the Americans with Disabilities Act. But it's tricky. You have to read up on it first. So, concept number one is you don't disclose a disability in an interview. You will not get there. You only do it after you have accepted the job. And then once you've accepted the job and you have that confirmed, you have the right to ask for accommodation, but you don't have to tell them everything. And technically, you don't have to tell them anything other than having a doctor's note that would say what the accommodation would be. So an example of an accommodation would be having a desk close to a bathroom. Or if you're a teacher, having a classroom near the restroom so that you could go to the restroom quite easily. Or ideally, if you're teaching kindergarten, having a classroom with a bathroom in the room. That's like the perfect example of a reasonable accommodation that would be appropriate in a teaching setting. But it gets tricky because no matter what we say, as much as we would like to say that our employers in our country is empowered and wants disabled people to work, hidden discrimination happens all the time. So I think that the longer you can withstand I mean, I don't know how to say this. Number one, Selena, you got to do everything you can to get as healthy as you can before you even start the job. Number two, it'd be really cool for you to talk with other teachers who have IC, who understand what they've done. Number three, you got to make sure you're eating really, really well so you're not accidentally doing things that would make it worse at work. Number four, you have to know your subtype, because if you have a bladder wall subtype from birth control pills or estrogen atrophy, we know what will help that, which is going to be an estrogen therapy and or a bladder coating that might give the bladder a little bit of extra protection. In contrast, if you're IC subtype 3 pelvic floor driven, then we're going to be looking at doing things that will keep your muscles as healthy as possible. Yeah, I know. She says, I'm hoping I'm going to be better than them, but I always want to be safe. Yeah. I just think that, I mean, I got canned for going out on disability leave. I got first time in my life I've ever been fired. And it was shocking, absolutely shocking that they only fired the 2 employees that were out on disability. I was out on disability to have a whole bunch of testing done. I thought I was dying of cancer. I didn't believe I had IC. I was sure I was dying of cancer with the pain that I was in. And my employer just, I mean, they broke the law, absolutely broke the law. I sued their ass for 5 years. I sued them. And I eventually won, but it took a terrible toll. It's not like I made a lot of money. I certainly didn't. Um, I got a printer in the end. We settled for $75,000. 50 or 60,000 went to my parents to repay for attorney's fees. I had to pay another attorney $10,000. There was something else I had to pay. I had to pay a lot of these fees. And in the end, you want to know what I got for a five-year lawsuit, disability discrimination? I got a new laser printer. That's all I got. So I don't know. Maybe do a little bit of research with a district you go into and ask around. You know, some schools are really good. They've got great principals who are very supportive, and some schools have crap principals who could care less. I think you're just going to have to kind of ask around and go for the lay of the land, so to speak. Sherry says, the past 10 years, I've had swelling and pain in my left leg. I've had so many tests done, several doctors, and no one can explain what is wrong. I have severe vaginal and rectal pain every morning. I have to sit on ice packs. Standing relieves the pain. I have to urinate 30 to 40 times a day.
Take everything out. Huh? What? Take everything out.
Sherry, I'm glad you bought IC 101. I'm glad that it's helped you understand. You're in between the urologist now because of the horrible insurance. Okay. So Sherry, like here's the deal. IC does not cause swelling pain in your left leg. It doesn't. That is not IC. I've never seen anything in 28 years that's talked about swelling and pain in your left leg. Never. That is not IC. That is not pelvic pain. Something is happening. And the swelling and pain in your left leg is musculoskeletal, or, I mean, it depends upon how much the swelling is, right? How severe the swelling is. Have you been to an orthopedic surgeon yet? Have you been to anybody? I mean, have you explained to them the swelling and pain in your left leg? Uh-oh. Deborah says YouTube is not live anymore. YouTube is not live anymore? Let me see here. All right, YouTube. I don't know. John says it's still live. Okay. Tyler, Tyler, I'm going to come back to you, dude. You hold on one sec. And I say that with love. I love to say the word dude. I'm not saying it in a mean way. I just love that word. All right. So, Sherry, have you told all these people about your swelling in your left leg? Is it high? Is it low? Is it in your foot, at your knee, or at your hip? What makes it better? What makes it worse? Are there any signs that you have a circulatory issue? To me, hon, this is like, like the devil is in the details. I say this every single time. That is a huge thing. You have swelling and pain in your left leg every single day, and you have severe vaginal and rectal pain every morning. You have to sit on ice packs all the time. So that's not your bladder. The rectal pain is not your bladder. The vaginal pain is not your bladder. It's in the calf of your leg. Have you had a pelvic floor assessment, Sherry? I mean, a bladder instill is not going to fix that. Do I think you have pelvic floor dysfunction? Hell yeah, I think you have pelvic floor dysfunction. But I think something else is going on. It's time. She says, "No, it is time for you to have a pelvic floor assessment. Like that's like priority number 1. And you need to tell the physical therapist you have pain in the calf of your leg every morning that swells. That's just not normal." Sherry, how old are you? And when did this start for you? Did you say 10 years? 10 years. How old are you now? Sonia says, I have been prescribed Z-Pak and steroids five times this year for bronchitis, and it calms my bladder and my pelvic floor for a few weeks after taking them. I feel normal when going to the bathroom at that time. So antibiotics have a mild anti-inflammatory effect, and steroids also have a tremendous calming effect. So it could be the legacy of that. Or I think some people on the internet would say perhaps you have a chronic UTI. And we don't, and those are guesses. Um, it's not surprising that you feel better after being on steroids and on Z-Pak to me. I don't think that suggests that you have a chronic UTI. Although if you're interested, you could do a next generation DNA urine test to confirm that one way or the other. Okay, so wait a second here. Sherry is 50 years old and she had a hysterectomy at the age of 31. Sherry, why did you have the hysterectomy? What was the reason by the hysterectomy? I don't know. Like my nose is so itchy. So why did you have that history? But why? Did you have an ovarian cyst? Did you have endometriosis? Okay. Okay. So when did the leg swelling start? Did the leg swelling start right after the hysterectomy? And do you associate that with any sort of event? So you had the hysterectomy at 31, but the leg thing didn't start until you were 40. What happened when you were 40? Were you in a car accident? Did you fall? Did you break an ankle? Hurt a knee? Anything? Fall in the snow? Did you ever have any doctor look at it? I mean, did you ever ask your general practitioner why your calf gets swollen? Okay, Tyler, I'm going to come back to you while Sherry's answering. All right, so Tyler. Men face unusual levels of criticism from other men. The single most important phone call I got was from a man who was sobbing. Like I answer the phone, "Hi, this is Jill, IT Network. Can I help you?" Just how I answer the phone. And this man was sobbing. He was crying so badly that he couldn't talk for about 5 minutes. So I just kind of talked to him. I was like, all right, let's take some deep breaths. We'll get through this. What he said stunned me. He said, I'm the chief of one of the biggest trauma units on the East Coast. And I have IC, and I had pain, and I've told no one. Because the minute I do, they will laugh at me and I will lose my professional reputation. And he started crying again and he goes, I can't do this anymore. And he started sobbing again. Imagine the chief of a trauma unit sobbing on the phone because he feared what his colleagues would say to him. Okay, this is real for guys. This is real. I had another guy who in my local support group who went to his urologist in Marin County, and the urologist said, oh, be a man. Fuck up. Don't talk about it. Don't tell anybody you have pain. Just be a man, right? For 5 years, this man did not even tell his wife he had pain. And he suffered terribly for it. And it's just a crime. And so I want you to remember, I mean, like, again, I always say this every meeting. There's no shame or blame in having pelvic pain. It's not your fault. You haven't done anything wrong. It doesn't say anything about you as a person. It's not what's wrong with you. It's what happened to you that matters. That at some point in time, you were traumatized. And dude, you were traumatized. You were injured. And for anybody to say that you have a mental illness because you have pain, it's just wrong. And I think, I can't tell how old you are, so bear with me here. The most important thing that you can do when you're working with doctors is, especially about pain, is you always have to focus on the cause of the pain. When you go to a doctor, say it's and you can never walk in and say I need pain care right away because you immediately look like a drug seeker. You have to walk in and say, I am trying to understand why this hurts. Can you please help me understand why I have pain in this location? So like I have another guy who's a very, very dear friend of mine now. And we just became very, very good friends. He's not a typical IC patient at all. He's a surgical injury patient where he was badly injured by a surgeon doing something else. And one of the things that he said to me is, Jill, it always hurts in this spot. And I'm like, okay, that's not IC because IC doesn't do that. If you have a general bladder issue, usually it's not in one specific location. Usually you would have sensitivity on the bladder wall so that you would have pain as your bladder fills with urine relieved by urination, right? But in his case, he had this throbbing little pain right in this one spot. I'm like, okay, that, and it was, if I remember correctly, it was like over to the left in like one spot. So, yeah, because it was in one testicle. It was in, yeah, okay. So what I said to him is, that's where we need to work. Is what's in that location that hurts? And he's like, oh, I don't know. I thought it was IC. It's like, no. What's in that location that hurts? We need to get doctors to study that specific location structurally. And to make a very long story short, when they opened him up, they found a gangrene in his one of his ducts. Such severe gangrene, it was black, and it literally turned into a puff of powder when the doctor got there surgically. He's done many, many surgeries to try to repair this. So when you're trying to work with a doctor about pain, you need them to study your body, and we need them to anatomically focus on cause versus effect. The pain is the effect. What's the underlying cause? Because if you show them that you want to fix the problem, if you say, listen, I would prefer not to need pain meds. Right now, I do. Right now, I have something structural going on that's quite painful. If we can get to the point where we can fix that structural issue so that I don't ever need to use pain meds, power to you. I'm ready for it. I'm willing to do just about anything not to be in this pain. But I don't understand what's causing this pain. And so, again, this book, Tyler, is going to help you immensely understand the physicality of it and why that pain would be occurring. Okay. So, anyway. Okay. So, Sherry had ultrasounds on her leg. She had arterial studies, vascular studies. They were okay. When you was 41, you started with rectal pain and this crazy leg swelling. So you had 2 colonoscopies, you have chronic IBS, which constipation IBS, which points us to your pelvic floor. When you have a bowel movement, it relieves the rectal and the vaginal pain. Your leg swells more the more you walk on it, and feels better when you have it propped up or off. Oh, honey, listen. Your case is a perfect example of why we have 3 different levels of doctors. We have local, regional, and national doctors. Your case is so complex, you are going to it's just you're gonna outpace local doctors. They're not going to have the expertise to work with you. You're going to need to be with a regional or national doctor at this point in time. It's too, and I really see them as being related but separate. Your leg swells the more you walk on it. Honey, I don't want to sound insensitive or rude or anything like that, and you don't have to answer any question. I mean, guys, seriously, you don't have to answer any question right now. Ever that I ask you, you can just gracefully say, I don't want to go there. Um, is there is weight an issue? Because for people that are quite large, that forces the pelvis to carry a lot of extra weight burden, which then, I mean, so thought number one is that, and then the other thing that it's kind of triggering me is actually pelvic congestion syndrome. Oh God, where was it again? I saw a study, and it was from oh God, where was it? Oh, I know where it was. It was the International Pelvic Pain Society. Was that it? It might have been another conference. Anyway, it was an interventional radiologist specialist in blood flow in the pelvis and pelvic congestion syndrome. And he brought these incredible slides of people who had this. So, again, pelvic congestion syndrome is basically the equivalent of a giant and engorged blood vessel. So let me see if I can draw a picture here. I have to wonder. I mean, it kind of supports. Here, hold on. Let's see. I'm going to see if I can draw a picture. Okay. Hold on. And let's. Oh. I'm doing this. I'm trying to do this from memory. And this is. Okay, hold on. And I'm using a Sharpie. I'm going to get high from this smell. Okay, and this is terrible drawing. Okay, hold on. It looks like a giant spider. Okay. I might be onto something here. Hold on. Does he have a picture that's in here? Ah! No, hold on. I know that everybody's probably getting ready for dinner. And you clearly, you know, I can talk about this stuff forever. Okay, so hold on. Okay, so if you divide the body down the middle, you divide the pelvis down the middle, you got blood vessels on the left side and blood vessels on the right side, and they're going all over the place, right? You got arteries and veins, et cetera, et cetera. And so in the pelvis, you've got blood vessels that go down into the legs. You've got blood vessels that support, you know, your clitoris and all that sort of area. You got blood vessels that support all the organs and stuff like that. So normally they're very balanced. And this is a terrible picture, but it's going to make sense. Okay, so normally left side to right side, it's flowing equally on both sides, and the blood supply is going where it needs to go with equal volumes. But if you have a vein that has become engorged, it literally presses, it presses, the sheer weight of it reduces blood supply to the other half of the body, to the other side. And then you see that poor blood supply go all the way down the leg. I mean, again, these are giant veins that interfere with blood distribution on the other side, or on any vein or artery that's near it. As it swells, it's going to compress them. And so there was this amazing slide that here, it was actually I think it was well, it was like a sonogram or something like that. And basically what it found in these patients with this is that all the blood supply was staying on one side and nothing was going over to the other side all the way down to the leg. I don't know, honey. I don't know. It's just it's triggering me to think about that to a certain degree. Okay, you had arterial studies, vascular studies in your leg, but what about in your pelvis? So the other thing here that I don't understand. So you have to understand that the irritable bowel syndrome could be related to tight muscles. And one of the signs of pelvic congestion syndrome is the day goes on and the more you walk, the worse you feel. But so your leg swells, the more you walk on it. I know. Thank you, Jennifer. I have a pretty good memory. Sometimes I don't get it quite right, but my dad has a photographic memory. And I have to say that there are moments when I realize that I've inherited part of that gift. I do tend to remember a lot of stuff. Would that cause the leg to go numb and cold? It could. It might. I don't know. To me, again, the devil is in the details. That's the missing piece of this puzzle, Sherry. I have to wonder about that. That is my guess. Deborah says, I fell on the boy's bike and hurt my pelvis. Honey, that is a classic injury that he talks about in this book. Classic injury right here is what happens with bike seats and bike injuries. And, it's just kind of like you just kind of realize, wow, there are no bones. I mean, look at it this way. Bike riding literally puts the worst pressure you could have on your pelvic cavity, because the only bones protecting you from the butt up are these two little sit bones. There's no bone right here. Yeah, you got a tailbone right here, but from your rectum to your vagina to your urethra or your testicles, there's no bony structures there. So when you're sitting on a bicycle, you're literally sitting on muscle and nerve. And the human body is not designed for that, period. End of story. So if you happen to love bike riding and you're on a bike I was working with a Hawaii Ironman, and his symptoms suddenly started. Did the prostatitis route, antibiotics, all that stuff for 2 years. Nothing helped. His mom called me. Can you help my son? He was 38. Like, sure. I call him. Happy to talk to him. I say, so tell me about it. He goes, well, I'm a Hawaii Ironman. It just happened for no reason. We go through the whole thing, going through all his symptoms. And I went, so how many hours do you spend a week on a bicycle? Well, he was riding like 200 miles a week to train. I mean, he's a really good Ironman. like, okay, have you ever heard about, bike rider syndrome? No. Well, that's sometimes happens. So let's go over your symptoms. So he could eat anything, which tells me that his bladder was reasonable. When is your pain the worst? Before you pee or after you're done peeing? After you're done peeing. Okay. Okay, that points us to the pelvic floor. A few other things. And I went, I think it's your pelvic floor. Have you had a pelvic floor assessment? And I gave him the reason why, the symptoms that he had. And I said, this is all kind of pointing not to your bladder, but to your pelvic floor. He said, I don't believe you. I got to pee at night. I'm up all night peeing. I just don't believe you. It's my bladder. And I'm like, well, your muscles can affect your bladder. And with what you do, it's a very good chance that you actually have a muscle injury. He goes, he basically cried bullshit, hung up the phone. They called me back a month later, crying. He goes, Jill, nothing is working. And his mom's worried about him. And I said, so what do you have to lose? Go get your muscles checked. He goes, I don't believe you. Hung up the phone. Called me back again. We did this 3 or 4 times. And I'm like, dude, what do you have to lose? What do you have to lose? Get your muscles checked. Just do it. Get your muscles checked. He got his muscles checked. What do you think he had? A massive pelvic floor injury. He called me from the car after the appointment. He's like, oh my God, you were right. It was my muscles the whole time. It's like, I know. I hope he's doing well. I haven't heard from him since. I would assume that he's doing better. Deborah said she had surgery at the age of 4 because she couldn't urinate. Wow. Ever? What? What did they do, hun? Do you know what they did? I have to remember that difficulty urinating and just like difficulty having bowel movements is often related to tight pelvic floor muscles. These are your shallowest muscles are your levator ani muscles. And what makes these muscles so unique and special is that they're the only major skeletal muscles that control major bodily functions because they have holes in them. For women, they have 3 holes. For men, 2. We've got a hole for your urethra, your vagina, and your rectum. So if these muscles are tight, what do you think is going to happen? It's going to squeeze those holes. And guess what? It's hard to let stuff out if the muscles are tight, and it's hard to let something inside, like a penis, if your muscles are tight. Urination is about relaxation. A muscle relaxes, sphincter opens, and you relax it out. If you are straining to pee, it's actually counterproductive because what you're doing is you're actually kind of confusing those muscles. The best urination is when you sit and you relax and you release. Think about when you're going to back when we used to go to places with multiple stalls and you're sitting there going, oh, I need to pee, and somebody comes in and they pee like a horse. And you're like going, oh, I wish I could pee like a horse. You're sitting there going, drop, drop, drop. That's in many cases because these muscles are very, very tight. If you've ever been diagnosed with a urethral stricture like I was in 7th grade, their answer to that back then was to stick a metal sound in there to just force it open. Nobody ever asked, well, why was her urethra narrow in the first place? Well, her urethra was narrow in the first place because of nerves and the long on my central nervous system. Deborah says she doesn't remember. They took a tube from my bladder to my kidneys. They took the tube from my bladder to, wait. They took the tube from my bladder to they took your ureter. Interesting. So are they saying that you had a blocked ureter? Wow, that's very complex. It's possible. Could have been a birth defect? Ah, interesting. So you had a blocked ureter. So what did they do? So they took one ureter. So did they replace it? I don't know what they would replace it with. I've never studied that. Hmm. All righty. Well, all right, guys. Listen, we've been going for, oh, wow. Man, I stuck it out pretty good, considering I had a pretty bad headache this morning. 4 hours. I think that this is our last meeting on YouTube of the year. On Facebook, I will probably be doing a support group meeting maybe on Thursday, or maybe the following Thursday. Um, so I want to wish you all a wonderful, joyful holiday season. Um, take time for you. Be safe. Stay home. Respect the COVID. It's real. Don't put yourself in jeopardy. It is just a day. And this is the gift of Zoom. We can still be with our friends on Zoom. Practice good stress management. Now, listen, with the food, here's the cool thing about, at least about the food over the traditional holidays that we do. It's usually pretty icy friendly. Aside from the cranberry sauce, the food is pretty good. And so be modest, enjoy yourself as much as you can. And ultimately, in the end, guys, Christmas, I almost lost my mom 2 weeks ago. And you were here, and she fell, and I had to shut down a meeting because she fell. The only thing I need for this Christmas is to hear her laugh and to know that she's safe. It's not about the food. It's not about the gifts. It's about being there for the people we love. And if you've lost somebody, think about how you can honor them. Think about something that was important to them, whether it's animal rights, whatever cause that was meaningful for them. Do something that would make them proud. And maybe a donation to another nonprofit of a cause that they supported. Like I have a cousin who has MS, so I donate to the MS Society on her behalf. No blame, no shame, no stress. No stress. The gift of winter is we get to rest. Think about the seasons: the spring, new life; the summer, maturity; the fall, harvest; winter, peace, resting. And so I want you to rest. I want you to do your I spies. I want you to sit by the fire with a book that you love, with a cat in your lap. I want you to step away from expectation. If your family has a tradition that you just never gelled with, you can create a new tradition. If you're in pain and they expect you to do something, you have the right to say no. You get to come first, right? And always, always, always know that you are not alone. There are millions who share your journey. No shame, no blame. It's not what's wrong with you, it's what happened to you. I encourage you, if you can. Prince Harry and Oprah Winfrey did an amazing series, an amazing show where I got that. It's not what's wrong with you that happened to you. So good. And it was about childhood trauma. And it was about what he went through when his mother was killed, and the trauma he went through with his after getting married. And but there's so much more to that. I mean, it's such a good, affirming, wonderful show. I would encourage you. I think it's on the O Network if you can to watch that. If you find somebody who's struggling, send them an encouraging word. If you have someone in your family who's alone at home, give them a phone call. Lighten somebody's day, even once. You know it's a good day if you can look yourself in the mirror at the end of the day and be proud of what you've done that day. Do one thing that makes you proud of yourself. Think of somebody else, not yourself. You know, one of the great gifts of starting a support group is before I started my support group, I thought I was the worst IC patient in the country. I was convinced I was going to die in a year. I started my first support group, and you know what? I found 300 patients in California alone. Then I started talking to them. It's like, oh, wait a second. I'm really not the worst. Oh my God, I actually have a pretty good compared to some of the other people. Context matters, right? The gift of meeting other people is it gives you context too. So anyway, I wish you a Merry Christmas. I wish you a Merry Christmas. I wish you a Merry Christmas and a Happy New Year. And I will see you on the other side. 2022 is going to be the best year yet. We're going to get through this together. And I appreciate every single one of you. So you all be good. Have a wonderful holiday. I will be around. I will be around. My hours are going to be all weird, but I'm going to be around. If you need an encouraging word, you know who to call. All right? Okay. I will see you later. Be well. Giant hugs. You know what these are? These are little mini hugs. See you later. Tyler, I wish you the best. All right. And if you want your ICN mystery gift, icnetwork@mac.com. Okay, I'll see you later, guys. Goodbye, YouTube.